Assalamu alaikum. Good afternoon, everybody, and it's so nice to meet you all once again. And we are now joining our fifth session of this important conference, the LPHA Palestinian. Okay, and we have four major speakers in this session. The first of them is Dr. Benjamin Bouquet, and he's from the World Health Organization. And today he's going to speak to us about converging barriers to accessing healthcare services for non-communicable diseases during the COVID-19 pandemic in the Gaza Strip. The floor is yours.
Good afternoon, my name is Ben Bouquet. I work with WHO in the occupied Palestinian territory, and I'm going to be presenting today a mixed method study on converging barriers to accessing health services for non-communicable diseases during the COVID-19 pandemic in the Gaza Strip. Presenting today on behalf of colleagues at Al-Quds University, Johns Hopkins University and WHO at the headquarters level, regional level, and the country office here in Palestine. So I'm sure colleagues on the conference will be well aware of the background, the context in the Gaza Strip, where non-communicable diseases are the leading cause of death and barriers to access mean worse health outcomes. The COVID-19 pandemic also was well recognized to have exacerbated barriers to access and had a disproportionate impact on certain parts of the population. And of course, in the Gaza Strip, long-standing barriers to accessing health services arise from the blockade and ongoing movement restrictions for Palestinians, fragmentation of services, and long-standing gaps in provision and resources. The specific research questions that we addressed were what barriers exist to accessing effective health services for adults with NCDs, so non-communicable diseases, in the Gaza Strip, with a focus on semi-rural communities close to the fence, and also specific disease markers that encompassed hypertension, diabetes, heart and respiratory disease, and cancer. And we asked how were these barriers then affected during COVID-19 pandemic. And the key research objectives were to outline barriers to accessing NCD care in Gaza within domains of the Tannous framework. And I'll come on to this in the next slide, and also to identify priority interventions to tackle barriers and facilitate access to health services. So this is the Tannous framework, which is used in WHO's global guidance on assessment of barriers to accessing health services. And once you've identified your target population within your policy or your research question, then of course there are different domains that affect effective coverage for the population. So you can see that the proportion that has access or effective coverage becomes progressively less as you think about the proportion of the population for which there is actually available services. Of the portion that has available services, then a smaller proportion can actually access them. And then of those who have and are able to access, then again, a proportion of those it will not be acceptable. So, or there might be acceptability barriers, and that means again a lower proportion. And then contact coverage is the proportion of the target population that actually has contact with a healthcare provider. So this is, and we'll see in a few slides' time, this is also in terms of services utilization, what we typically think of. And then effective coverage, of course, is relating to adherence in terms of investigation and treatment regimens to gold standards. So different parts of the population are disproportionately affected by barriers, and this is a key aspect or key philosophy that's underpinning the barriers assessment, is to understand how those different barriers affect certain parts of the population. This is not by any means a prescriptive list, but and it's recognized that barriers are socially or politically produced. but these will encompass aspects such as place of residence, race and ethnicity, occupation, etc. And this is to probe thinking about stratifiers or vulnerabilities that will be differently manifested in different populations. So, as I mentioned, the study used mixed methods. Literature review identified 120 documents across the OPT that were relevant to the research question. And I haven't gone into detail on this because of lack of time of the method that was used for literature review. There was secondary quantitative analysis for data that was provided on services utilization by the Ministry of Health and UNRWA for the Gaza Strip, and this compared data from 2019 and 2020. And then there was qualitative data collection through 35 key informant interviews in the Gaza Strip with healthcare providers, policymakers, and community leaders. So as I mentioned, contact coverage is the proportion of the population that actually reaches service. So when we look at services utilization data, we're looking at contact coverage. And this is a useful indicator for all the aspects that precede that contact. So we mentioned them already, there being availability of a service, there being access to that service and acceptability of that service. And we can see that in 2020 compared to 2019, there was a reduction in services utilization across indicators for primary care, secondary care, and tertiary care. And this disproportionately impacted on certain disease markers. So you can see for primary care or NCD visits to primary health care, the drop was larger for diabetes than it was for hypertension. It also disproportionately affected certain specialties. So you can see in secondary care that the reduction in outpatient appointments overall in September of 2020 of 97% compared to September in 2019 was greater than it was for the reduction in oncology or hematology outpatient appointments, which reduced by 27%. And in the Gaza Strip, there was actually an increase in chemotherapy appointments in the Ministry of Health by 78% in June of 2020. And this relates to the next point, which is that there was a reduction in referrals to non-Ministry of Health providers. And of course, historically, there being a strong dependence on referral out of the Gaza Strip. And this, you can see that there was a disproportionate impact on the Gaza Strip compared to the West Bank, where in the West Bank it was just an 8% reduction in referrals. So for the domain of availability, just to present quickly some key findings here, we see that there was closure of primary healthcare services as there was a shift to emergency response. So just 12 of the 54 Ministry of Health primary healthcare centres in the Gaza Strip remained open during the whole period of COVID-19. And we can see where there were, for example, one provider had 6 mobile clinics, which were all for non-communicable diseases before COVID-19. 5 of these became designated for COVID-19 during the period of the pandemic. Similarly, in hospital, and I mentioned in the previous slide, some indicators for that, reduced services provision, particularly, for example, for outpatients, where there was a shift to COVID-19, but also overall a reduction in services utilization and reduced issuance of referrals. That really shows the interconnection of the availability and access domains, where reduction in referrals was related to restrictions in Israeli eligibility criteria for permits during COVID-19, and also the intercoordination between the Palestinian Authority and Israel. And then chronic under-resourcing was then also exacerbated during COVID-19, where staff were particularly affected, and this came through very strongly in the key informant interviews, where staff reported being overworked, facing long hours, having to shift their functions, and of course, especially when teams were hit by COVID-19 and would be in quarantine themselves, then that would put, again, another burden on those that were remaining in work. And then the long-standing gaps were exacerbated in many instances, and just an example here of how that lack of availability also impacted on effective coverage. So Herceptin in the Gaza Strip the example was given where each patient who needed 17 doses was only getting 5. So the lack of availability then impacting the effectiveness of the treatment that was given. And then certain services were disproportionately impacted over others, and we can see that the less medicalized services were more impacted, were disproportionately impacted compared to hospital services, for example. So a reduction in outreach services, and we can see, and also in some multidisciplinary style services, such as one intervention that was quoted by a provider that used a microclinic international approach involving group sessions, focus on patient capacities, so trying to increase adherence to treatment regimens, but these facing being largely stopped to shift and focus on the medical provision of care and emergency response. Accessibility looked at 4 specific areas, so geographical and political, financial, organizational, and informational access. I already mentioned some of the geographical, political access barriers. For financial, where there are long-standing, again, financial barriers such as out-of-pocket payments, co-payments, all related also to lack of drugs in the public system. These were exacerbated by the social impact of COVID-19, which saw higher unemployment, again, a larger impact on those in the informal sector as well, and reduced outreach, meaning also an increase in indirect costs, such as for transport. Organizational, so as well as stopping of services, there was reduced working hours for NCD services, and then a lack of a comprehensive list of NCD patients meant that there had to be appeal through social media and broadcast media for patients to register for medicines delivery, and of course that potentially missing those that had less access. And then there were gaps identified in systematic or tailored communications around opening times and appointments, but also around non-communicable disease risks. In terms of acceptability, then specific acceptability barriers that were quoted by key informants included perceptions of poorer quality, which related to knowledge among the public of gaps in the Ministry of Health provision of care, overcrowding in certain services, also the perception that if you're paying more for a service, it's a better service, and that negatively then affecting public service provision. Perceptions around discrimination or wasta, so including attitudes that were quoted by key informants related to appearance or status of those being treated, potential gender-related barriers that could relate to certain paternalistic attitudes of some providers, and then stigma associated with disease itself, such as cancer or COVID-19, being an inhibitor for patients then going to access services. And there was also quoting of the issue of mistrust of authorities, where evidence for that was shown as the lack of uptake of COVID-19 vaccines. And then I already mentioned the link between effective coverage and availability, so those linking specifically to late and inaccurate diagnosis. But then there's also discrepancies in care and approaches, so lack of standardized protocols, which were not always present. Also lack of adherence among patients relating to the ineffectiveness of lifestyle recommendations, and then of course the lack, as we already mentioned, of availability of more multidisciplinary approaches to uphold that and to support patients in changing their lifestyles. And then fragmentation of care horizontally and vertically, that's well recognized being a major challenge that was also quoted. So strengths of this study include that it gives a comprehensive and useful framework for understanding effective coverage and access, where access is obviously recognized as a critical issue relevant to the Gaza Strip. Multiple methods were complementary and gave strong insights and rich data for further analysis. Some of the limitations include lack of ability to engage with root causes through this analysis, that the broad research question meant synthesis into practical recommendations was certainly a challenge. And then a focus on supply side currently means a need for stronger engagement with the demand side of services. And then our key recommendations include to outline a vulnerability framework that's applicable to the Gaza Strip and to Palestine more generally, to enhance information on entitlements to health services to address some of the barriers related to mistrust or perceptions of favoritism, to map and build on multidisciplinary good practice models, some of which were identified, and to strengthen evidence for how those can be improved. And then to strengthen also participatory mechanisms and community dialogue to inform needs assessments and models of care and tackle stigma, and then to build advocacy to address root causes of ill health. So that concludes this presentation, and many thanks.
Thank you, Dr. Ben, for your nice presentation. All comments, questions, and answers will be given at the end of this session.
Sorry, everyone. I think there was a connection problem with Dr. Khamis. We'll share the second presentation, which is by Dr. Bassam Abu Hamad from Al-Quds University in Abu Dhabi, and the title is Falling Through the Gaps, Barriers to Accessing Essential Non-Communicable Services During COVID-19 in Area C. So we will commence Bassam's presentation. Thank you for your patience.
Greetings for all. I'm Bassam Abu Hamad from Al-Quds University. I'm presenting this study about the barriers to accessing essential non-communicable services during COVID-19, focusing on Area C. This work has been conducted in collaboration between WHO, Johns Hopkins, and Al-Quds University. The study focused on adult population with NCDs. We focused on 5 marker conditions: hypertension, diabetes mellitus, heart disease, pulmonary disease, and cancer. The study is focusing on rural communities and semi-rural communities. However, today in this presentation focusing on Area C, which comprises around 60% of the West Bank, and people living in this area, which is under the direct control of the Israeli authorities, are facing multiple challenges and operations by the Israeli occupation, including denying their rights to access services, including health services. The study is part of a pilot activity conducted to prepare an emergency-specific annex to the handbook for conducting assessments of barriers to health services, which is being currently produced by WHO in collaboration with Johns Hopkins. The study adopted broad definition of accessibility, including physical, financial, social accessibility, and organizational, informational, and also adopted the Tannous framework. The objectives has been phrased according to different parameters of the Tannous framework, looking for the barriers in availability, barriers in accessibility, barriers in acceptability of the services, and also barriers which prevent contact and effective coverage as well. We followed a mixed method approach comprised of reviewing the literature review. We reviewed around 120 documents, including referred articles, UN reports, Ministry of Health and UNRWA reports, master thesis, and PhD thesis as well. And we complement that with secondary analysis of the quantitative data available at service provision. For Area C, we relied on analyzing the data collected at UNRWA health centers in the West Bank. And we conducted empirical key informant interviews with 66 key informants from West Bank and Gaza, 31 from West Bank and 35 from Gaza, and data from all sources triangulated to allow multi-layered analysis. The key findings, the key barriers related to the availability of services. Despite the availability of large number of health facilities, West Bank and Gaza, we have around 80 hospitals, around 800 primary healthcare centers, However, rural areas are disadvantaged as the majority of primary healthcare centers in the West Bank are level 1 and level 2. And these level 1 and level 2 centers serving rural populations because primary healthcare centers are designed based on the population size, and these areas are less populated than large city, therefore tend to be less advantaged than larger communities. Israeli measures like checkpoints, separation wall, Israeli aggressions, make even the available as unavailable, especially in area C, Sim Zoom and H2. In addition, by design, the UNRWA services are not vulnerability sensitive, and people with NCDs in rural areas are served like others. There are no specific program, no vulnerability sensitive, no vulnerability sensitive NCD programs or services to target them. In addition to that, health facilities serve people who present to the clinics, but no proactive targeting, and limited do exist, and limited outreach program are there. The mobile team are doing great work. However, these are not adequate to meet all the needs of the population. Even when services are available and facilities are available, still there are shortages in human resources, especially specialized human resources, lab services, supplies, and the drugs. And level 1 and level 2 clinics serving rural communities are in particular disadvantages. With COVID, the pre-existing barriers continued, and in addition, new ones come into play. Like, for example, small clinics serving rural communities were closed, and the staff from these clinics redeployed into larger centers, serving big cities. Therefore, people living in these areas face greater accessibility problem during COVID-19. In addition, during certain periods, primary healthcare centers, outpatient services at hospitals are closed, and some hospitals either turn to work entirely in COVID services or shifted to emergency mode in order to focus more on the COVID-related services. Also, the restrictions in movement between governorates also added another layer of complexity, and referral services tended to be more complicated. In terms of accessibility-related barriers, with the measures practiced by the Israeli occupation, access is more restricted and more constrained to people living in area C, Sim Zoom, and H2. And also, the mobile team themselves, they face problem in reaching these areas, or they don't have the funds to cover all the services, and the Israelis and the settler measures constitute a significant barrier to accessing the services in these areas. Elderly people with disability in particular face greater barriers related to accessibility than other categories of the population. Regarding financial related barrier, the healthcare system face greater financial barrier like dependency on donor, catastrophic health spending out of pocket represents around 40% of the total health expenditure, and co-payment constitute a real barrier, especially for people who are facing economic challenges. And during COVID, more people face from financial crisis due to loss of employment during COVID. Therefore, some people skip the services, or they ask sometimes service provider to select among, for example, the 5 or 10 drugs, which one is the most essential, because they don't have the resources to pay for the co-payment. Also, transportation for people living in rural areas are expensive, more than big cities where the transportations are more available. And with the restriction in movement and limitations on transportation services even become more expensive to people. While people who are economically better off can seek services at the private sector, economically disadvantaged people don't have this option. Therefore, they face a greater financial problem. Data from UNRWA health facilities, really provided interesting stories, which really shows how much the contact coverage has been reduced during COVID. We compared the data 2019 with 2020, and we noticed that the reduction between the 2 years, in terms of the number of people with diabetes mellitus who received services at UNRWA clinic is less by 25%. Also, the number of people with diabetes mellitus who received laboratory services reduced by 63%. Also, the number of people with diabetes mellitus who received drugs reduced by 28.7%. The same applies also to hypertension. People who received services for hypertension reduced by 16%. People who received lab services with among people with hypertension reduced by 41%, and people who received the drug reduced by 26%. And this is the difference between 2020 and 2019. Despite the first 3 months of the month, we don't have COVID at that time, and the state of emergency declared in March. So the annual reduction in reality is higher than that. This study is unique because it followed a mixed method approach. We collected data from different sources, which allowed for in-depth multi-layered analysis. Also, the Tannous frame is an interesting frame that is not widely used in the OPT. However, there was variations in how people understand the concepts or in availability of resources. One of the major limitations of this study that we focused on the supply side, so we talked to key informants, and we did not talk directly to people with NCD, except we talked to some community leaders and the community. Ideally, we should talk more. We should be engaged directly with people, but because of the COVID measures and also because of the budget limitations, we were unable to engage directly in discussion with the people with NCDs themselves. Also, responses relied on self-reported responses, which is not necessarily accurate, and or at least the degree of precision is less than other data collection methods, especially with the lack of baseline. And lastly, it's really important to ensure the provision of comprehensive health services for all citizens at all circumstances. A package of essential services for people with NCDs should be identified, standardized, because we noticed variations between one provider and the other, and applied by all actors. Also, it's really important to formulate a policy to ensure the protection of vulnerable subpopulations at all circumstances, and to ensure that they have access to services and they receive appropriate services at all circumstances. It's really very important to scale up the outreach program and the proactive targeting for the effective management of NCDs services, and also to increase the orientation of services towards the prevention services, because most services are curative. So it's really important to invest in preventive services. In terms of emergency preparedness, it's really important to increase the level of emergency preparedness, and any emergency preparedness plan should ensure the provision of essential NCD services and conceptualizing that within a human right-based approach in order to uphold equitable access to services at all circumstances. Also, it's really important to invest in multi-sectoral intervention to address gaps in accessibility for rural populations and disadvantaged population. For example, liaising with social protection programs and liaising also with advocacy activities, including better surveillance and monitoring system. And it's essentially important to enhance the model of care, continuity of care, system connectivity across all levels for the promotion of patients' participation and empowerment, as well as meaningful accountability mechanisms for right holders and duty bearers. Thank you very much.
Thank you so much, Dr. Bassam, for your nice presentation and comprehensive study using mixed method. We'll now move to our next speaker, who is Dr. Lama Shakhshir from the Institute of Community and Public Health at Birzeit University, West Bank, occupied Palestinian territory. And she's going to speak about COVID-19 amid Palestinian refugee camps in the West Bank, responses and impacts. The floor is yours.
Hello, my name is Lama Shakhshir, and I am a researcher at the Institute of Community and Public Health at Birzeit University. I'm very delighted to be with you at the Lancet Palestinian Health Alliance Conference to present our findings regarding the research project I have been working on with Dr. Hammouda. My presentation is entitled COVID-19 amid Palestinian refugee camps in the West Bank, responses and impacts, and it's a part of a big project regarding health system strengthening. The outline of this presentation consists of an overview regarding COVID-19 and refugee camps, then the study aims and the used methodology. After that, we'll move to our study results, conclusion, and recommendations. COVID-19 has been a global situation. It was particularly challenging for Palestine living under occupation and having an under-resourced health system. Its impacts were not the same even among the same population. They were more intense on most vulnerable groups, including elderly people, people with chronic diseases, and those with low socioeconomic statuses. Health and social protection systems struggle to meet the needs of the population, especially in under-resourced and vulnerable settings like the occupied Palestinian territory. Now let's take a look at refugee camps in the West Bank and why we chose them or why we focused on them in our study. Refugees in the Palestinian context are unique in a sense because they now consist of around 4 generations of refugees, many of whom became refugees following the 1948 Arab-Israeli War, and some displaced again or for the first time in the 1967 Arab-Israeli War, or in between this period. According to the UNRWA, there exist 19 refugee camps in the West Bank. More than 871,000 registered refugees live in the West Bank, and a quarter of them live in camps. Refugee camps in the West Bank are known with their narrow streets and adjoined houses. As you see here in the photo, this is the Askar camp near Nablus city. They are densely populated and people there live under poor conditions, including inadequate sanitation and public services. They also face greater uncertainty due to displacement, legal standing, and loss of property, and they have a greater exposure to political violence as well. A 54-year-old Palestinian refugee that we met during our field work described the situation in camps, saying, in fact, the social environment is tough. The refugee camp became a place that I call housing prevalent. Many refugees started looking for places outside camps to live in. Many of them depend on loans. So our study aims to understand the nature of COVID responses in the West Bank refugee camps and to understand the Palestinian health system's ability to meet the needs of refugees. For this, we chose a qualitative research method. We conducted 27 semi-structured interviews with community members, local authorities, health providers, and high-level policymakers and managers. The chart on the right summarizes the number of interviews classified by the type of organization. As you see, we conducted 10 interviews with the local community of several refugee camps in the West Bank, 9 interviews with professionals working in the governmental sector, 4 interviews with local non-governmental organizations, and 4 interviews with international non-governmental organizations. Our interviews were conducted between April and July 2021. All of them were in Arabic except one interview that was in English. We prepared our interview guide in reference to our target group. We asked various questions about the way the pandemic affected both the population and the health-related organization. Additionally, the way the pandemic was responded to, which obstacles were there, and what were the factors that facilitated the response. We interviewed our participants using phone calls, Zoom meetings, and in person, depending on their preference. After the data collection process, we analyzed our data thematically using MaxQDA. Our results are divided into 3 parts. The first one is about the nature of COVID responses in the West Bank refugee camps. After analyzing our data, we ended up with 5 themes related to this part. So let's talk about them in details. The first theme is crisis management inside refugee camps. This theme was illustrated by the formation of an emergency committee in addition to a number of subcommittees to control the pandemic situation inside the camps. The emergency committee or emergency committees inside camps were in direct contact with the ones formed in the nearer governorates. The second theme describes the way susceptible and confirmed cases were dealt with. Our respondents mentioned that susceptible cases were tested and diagnosed, triage centers were established in front of the UNRWA health clinics, contact tracing was conducted as well. Regarding the infected people, they were isolated, supported, and followed up. Now we have our third theme. Our third theme is about prioritizing health-related services for COVID and non-COVID patients. Health providers did their best delivering health services to refugee camps during the pandemic. For example, the UNRWA provided those with chronic diseases with their medicines with a quantity that was sufficient for 3 months instead of 1 month. Our participants added that certain health services, especially those that required direct contact with patients, were suspended, whereas others did not stop. Our fourth theme is about the ways refugees were supported during the pandemic. Participants explained that different types of support, including financial and psychosocial support, were provided from different bodies. However, an internal support was remarkable inside the refugee camps. This was described by refugees' solidarity, cooperation, and local initiatives. Finally, our fifth theme is about communication, or in other words, the way refugees were informed about the pandemic. Social media was a source of information for refugees. Our participants from the camps, local centers, and health-related organizations mentioned that they shared COVID-related information and updates on their social media channels as a way of communication and raising awareness. So, as you see, here are our 5 themes that illustrate COVID-19 responses in West Bank refugee camps. Our second part of the results is about the elements that facilitated COVID responses in refugee camps in the West Bank. According to our participants, these elements were first, refugees' understanding of the situation, moreover, the initiatives of camp's local community. A good example on these initiatives is the youth center that was transformed in one of the camps into a COVID treatment center. And by the way, the healthcare staff were volunteers from the camp itself. A member of camp's local committees explained, it has been a while and the youth center has not been used. They invested in it during the pandemic and turned it into a health center. For certain cases, like my mother's, instead of going to the city while being tired, we visited this center as it's very close. We arrive within seconds, and it's really a good initiative. Another element is the good coordination between responding bodies and the efficient professional networks the local committees have. And now we have a very important element also, which is refugees' trust in local committees in the camps. According to our interviewees, this increased the level of commitment to the imposed security measures. So trust in local committees was very efficient. Finally, a strong social relations inside the camps was also an element that facilitated the response, as it helped getting to know those in need to support them. Since responding to COVID has been challenging, there were certain obstacles that prevented a fast and an efficient response. These included, first of all, shortcomings in financial, medical, and human resources. And also we have the logistic issues. Here, I'd like to add a quote from one of our respondents from a camp local center who explained, "One of the essential things we lack in the camp is the ambulance. Many people died because of not having the ambulance on time. Ambulances should have arrived faster." Another obstacle was the insufficient support as needs increased during the pandemic, which led to a lack of commitment to security measures among refugees. However, the lack of commitment was an obstacle on its own. Finally, we have the fast spread of fake news. This was also a big obstacle to deal with. Here also, I'd like to mention another quote from a local committee member who said to us, "We might have had logistic issues, but we overcame them more than we were able to overcome the fake news issues and those who spread fear and panic among others." In conclusion, the overstretched Palestinian health system did not fulfill or did not adequately fulfill the needs of the refugees during the pandemic. The role the local community played was evident and helped cover some of the gaps in needs. Other important point to mention is that camps' local centers cooperated and coordinated effectively between each other. And finally, it was clear that trust in leadership enhanced commitment. So, in reference to our results, we suggest two types of recommendations. The first one is addressed to the policymakers. It would be great to enhance the communication with the population and to make decisions in reference to the community needs. Also, we suggest to set up a contextually relevant risk management plan that takes into account the local conditions and the available resources in order to increase our preparedness for any upcoming unexpected events. Moreover, to promote the role of local communities by supporting the local centers in camps and enhancing the local initiatives there. For the health providers, we suggest to invest in health education and in raising awareness inside camps. Also, it would be good to cooperate with other health-related organizations and to expand the partnerships with international organizations, as this could enhance the health service delivery to refugee camps. Finally, to facilitate the access to healthcare services for refugees, We know that even without COVID, health services in camps were inadequate, so COVID was an additional burden on refugees. Therefore, we suggest increasing the health centers inside camps, but to make sure that they include several specialties and they open during the evening and or night shifts, so that people in need of an urgent healthcare service would not need to go outside the camp looking for them. Neither would they need to wait until the ambulance comes to transfer them. And that brings me to the end of my presentation. Thank you so much for your attention.
Thank you so much, Dr. Lama, for your informative presentation. It's clear, comprehensive. Now we'll move to our last speaker, last but not the least, Dr. Khalil Abu-Naqera from UNRWA head office in Jordan. And he's going to speak about the importance of community engagement in COVID-19 response, UNRWA Jordan field experience. The floor is yours, please.
Hello, everyone. This is Dr. Khalil Abu-Naqera, working with UNRWA at Jordan Field Office as Field Disease Control Officer. I'm happy to present our presentation titled The Importance of Community Engagement in the COVID-19 Response, UNRWA's Jordan Field Experience. Our presentation will be somehow different than standard study or standard abstract. We will take you to the journey of the community engagement and initiative. Together, we fight COVID-19. Our journey began on 17 of March 2020, when the government of Jordan implemented various measures to contain the spread of the COVID-19 virus, such as imposed total closures and movement restrictions. The complete closure imposed by the government continued for several weeks. Also, UNRWA health centers were closed in line with these measures. Due to this circumstance, non-communicable disease patients were not able to reach out to their life-saving medicines, NCD medicines. Suddenly, all 78,827 registered NCD patients became predisposed to disease complications. The aim of this study to describe UNRWA's Jordan initiative, Together We Fight COVID-19, as a community mobilization campaign, and also to describe how cooperation between the healthcare providers and the local communities, as well as the sharing of opinions and decisions, play an essential role in overcoming difficulties and achieving goals, despite the challenges during the pandemic. What was our approach, or what we did? As I mentioned before, the complete closure imposed by the government continued for several weeks, and our non-communicable disease patients were not able to reach out to their life-saving medicines, NCD medicines. Then we had to act to support our beneficiaries, and we decided to delivering the NCD medicines to the patients' houses. But still we have challenges. Huge number of registered patients with NCD. We didn't have the required logistics. We didn't have enough human resources because we were granted only 60 movement permits by the government. That's mean only 60 health staff were working from the health centers. And movement restriction is still imposed by the government. With all these challenges, the community engagement initiative has evolved, and idea was discussed with community leaders and various community groups. And then the initiative started through a collaboration with various community groups and established a volunteer matrix within and outside the agency. The attached pictures in this slide showing local community volunteers ready to deliver medicines to patients after training on infection prevention procedures before delivering the medicine to patients. What was our procedures at the health centers in that time? Started with doctors, processed the issuing of medicines in the e-health system. Then pharmacists pack the issued medicines in brown envelopes as showing in the attached picture in this slide, with label has beneficiaries information. Clerk and other volunteers make a phone call to the beneficiaries, informing them the delivery of medicines to their homes, confirm their home addresses, and someone will be available to receive the medicines. And finally, a list of patients' names, phone numbers, and addresses is given to volunteer delivering the medicines. On another hand, after the movement restriction was removed, and during our visits to the camps, we noticed that our refugees in the camps are not compliant with health advice in the markets. Then an idea came to our mind to protect the lives of refugees in the camps from a potential outbreak. We thought of empowering the community to protect themselves, discussed with other local community organizations about this idea and with community leaders. And our plan was to train 10 or more educated youth from each camp on COVID-19 diseases, infection prevention, hand hygiene, cough etiquette, physical distancing, and communication skills. The attached pictures in this slide showing trained volunteers visited shopkeepers to raise awareness and talk to pedestrians in the streets, visit community organization in the camps, visit people's houses. And in this picture showing volunteers are wearing UNRWA vests and caps for visibility purpose by the community. Also, training sessions for community volunteers were held in presence of the police and community leaders to praise UNRWA efforts and stress the importance of regularly checking the source of information. During COVID-19, based on our e-health system at UNRWA, we managed to extract the total number of patients eligible for NCD medications, which was 78,827. And based on this collaborative work, successful initiative, and community engagement, we were able to deliver the medications for 2 months to more than 74,798, which was almost 94% all over Jordan. We found out that how much it is important to engage the community in the design, implementation, and monitoring of future projects in other health emergency response pillars, and how much it's important to collaborate between the healthcare providers and the local community, as well as the sharing of opinions and decisions, play an essential role in overcoming difficulties and achieving goals. Finally, I will not be able to present this presentation without the huge work of all UNRWA staff, even those who got the permission move freely during the lockdown, or even those who were able to work online despite many technical challenges. Thanks also to my colleagues in the Jordan field, Dr. Mustafa Hamouda, Dr. Bi'innaqa, and Dr. Shtewi Abu Zaid. And thanks also to my colleagues in the headquarters, Dr. Akahiro Sita and Dr. Yusuf Shane. Thank you for your time and thank you for listening.
Thank you all speakers. Thank you all. I think now we have plenty of time for discussion and to direct your questions or add some comments to the presentations of 4 speakers. We have with us Dr. Benjamin Bouquet, Dr. Bassam Mohamed, Dr. Lama Shakhshir, and Dr. Khalil Abu-Naqera. So let me start with a question in the chat here. I think this question goes for Lama. And the question goes, when you say trust in leadership, whom are you referring to? And the second is, what do you think are the barriers of preventing building settlements, like housing, building settlement-like houses for Palestinians, like settlers?
Okay, thank you so much, Dr. Khamis, and thank you everyone for having you in this presentation. And I will start with the question regarding the trust. I think that since COVID-19 or the responding to COVID-19 was multi-level, so I think that every step, of course, is important. And since the response was from different bodies, so every organization, health-related organization, or every sector has its own role. So trust was very important, and it was really important element. And we noticed this during our field work with refugees. They said, for example, they commit to this or to this point in terms of response because they trust the body, or they trust the organization that they did the step. So, for example, they trusted local committees in general, because local committees are a group of people who they are aware of refugees' needs, and they are refugees themselves. So the population or the community, they trusted this group, and that's why they commit to what they ask them to do during the pandemic in order not to increase the disease transmission, etc. So in general, like trust here, I can refer it as a general term, and for the organization, or we can say the body that provide the service, the health service, or other types of services.
Okay, thank you very much. We have another question here for Dr. Khalil from Jordan, from Dr. Jennifer. What's the geographical spatial distribution of these camps, and what distances patients have to travel to reach, what distances you have to travel to reach 75,000 individuals?
Thank you, Dr. Khamis, and thank you all for your attention. UNRWA, we have clinics UNRWA in Jordan, relocated in 4 areas, in south and north, and in middle. We talk in 4 areas: Zarqa and Amman, South Amman, North Amman, and Irbid area. But in general, we have in middle and in south and in north. So we have 25 health centers. And we try to reach all our beneficiaries live inside or outside camps.
Good, thank you. Actually, another question to Dr. Khalil. They're asking, did this initiative included a referral mechanism for NCD patients who might have to be in need for hospitalization beside their need for continuous supply of medications?
Unfortunately not, because this is also only include deliver medicine to patients' homes. And in this point, we already have ambulance and our civil defense for hospitalization and refer to hospitals.
Wonderful. A question for Dr. Lama. How did you identify your key informants in the refugee camps in the West Bank?
Sorry, could you please repeat the
Oh,
question?
sorry. How did you identify? It's a question from Dr. Jennifer. How did you identify your key informants?
Yes. Okay. So the key informants, how did we identify them? Because in camps in general, there are centers like health centers, sorry, not health centers, there are centers particularly working with refugees and in direct contact with them. And in addition to these centers, like there are youth center, we can say the community centers. So youth center, women's center, and center for elderly people, and another specialist center for people with disabilities. And there are also local committees. So local committees, they are a group of people who provide services to refugees. So in terms of the camps community, these people are, we can say they are important, and these people are those who are in contact with refugees and in contact with very aware about the needs of the refugees. So since they are in direct contact with them, we thought that these people are very important to be interviewed in our study and to know more about refugees through them.
Okay, thank you. Actually, we have in the chat also a question for Dr. Ben. Here, this question says, can you reflect on the implications you're finding for NCD services as part of pandemic preparedness? Of course, future pandemics, and we hope it will never happen.
Thanks. Yeah, I think maybe several points here. First of all, the kind of implications from a structural point of view for the health system. So the pandemic obviously exposing structural vulnerabilities that exist at different levels. I would say one of those already exposing the inequities that exist within the Palestinian health system, and how patients in Gaza have been disproportionately affected by the pandemic. So I think that point really should be underscored in terms of thinking about lessons learned and going forward. And this, of course, relating partly to chronic gaps in availability, that then, I mean, if you're talking about things like pre-positioning of supplies, if you're already lacking essential medicines, essential supplies in the health system, I mean, you're away from the kind of framework of thinking about preparedness, you're already kind of trying to chase the gaps that exist. There were some specific lessons around health information systems. I mean, that was really quite clear in terms of ensuring sustainability of services to NCD patients. So clinics that had already, or providers that had already identified a list of patients with specific non-communicable diseases were then able to much better respond and reach those patients and deliver essential medicines that they needed for their care. Whereas if you look at it from the point of view of, for example, some of the Ministry of Health clinics that didn't have registers or registries for patients with non-communicable diseases, they sort of had to appeal through social media to then be able to reach those patients, and that obviously missing then patients that didn't have access. There were also some lessons in terms of response and adaptation. So I think the lack, we flagged that in the recommendations, the lack of a clear kind of vulnerability framework. And I know that there's sensitivity to that word vulnerability. It sort of places the onus on the groups that are made vulnerable by structures. And so we should always be mindful that we're talking about structures when we talk about vulnerability, but it was very clear, I mean, the impact on referral patients, to identify them as a group that really needed very strong attention and strong advocacy during that period, who in many instances were unable to get access to, you know, very essential care, thinking about cancer care, etc. And again, also, as we mentioned in the presentation, around preparedness for non-medical interventions. So thinking in advance how health human resources are going to be redistributed and the potential impact that that could have, and ensuring that there is some aspects such as patient-to-patient support or peer-to-peer support, stronger civil society support, and ways to reach out to patients who might be cut off otherwise. And then, of course, I mean, we can't talk about structural vulnerability without mentioning the vulnerability that arises from the occupation and the blockade in the first place. So, I mean, there again, the disproportionate impact on referral patients was really underlined, and the at points during May, June, and July during 2020 where patients had almost no recourse to even apply for a permit to reach some of the services that they needed to. I think that really underscored important lessons there to flag to duty bearers, to all the duty bearers involved in ensuring that right to health is protected. And that was really a massive failure there. Over.
Thank you very much. I have an additional question here for you, Dr. Ben, and it's on the lack of essential drugs, especially anti-cancer and drugs for cardiovascular and renal issues. And we have that this statistics which is going on and on and on for the last 16 years. We have at least more than 40% of all essential drugs are lacking in the Gaza Strip. And unfortunately, patients who are going to be treated abroad, they cost huge amount of money. Just last year, the government paid more than 200 million shekels just for referrals from Gaza to be treated elsewhere in the West Bank, in Israeli hospitals and elsewhere. So is it possible that WHO thinking of making available these drugs for good inside the Gaza Strip, or having maybe some sort of local manufacturing mechanism inside the Gaza Strip of these drugs, if it can be manufactured, at least for those drugs which need to be available all the time, taking into consideration that more than 40% of all patients, when they apply for permission, they are being rejected by Israeli forces, and this causes their cancer situation to be deteriorating and leaving them no chances to be cured, at least even if they were referred abroad, but still their prognosis is becoming worse. Here I wanted to cite a very good work that's been done and still being done by our great friend, Dr. Mads Gilbert, who's working day and night to make a facility that has been lacking in the Gaza Strip for the last 70 years. He's trying all his effort with the help of WHO to make it available, which is radiotherapy. All our patients are being referred abroad for radiotherapy because we don't have any department to offer radiotherapy for cancer patients. And now our dear friend Mads Gilbert, with support from different governments and especially from himself and WHO, are working to make this a reality. Hopefully very soon, or in the coming months or years, we can see this as a reality. So my question, is there a chance of having local manufacturing of these drugs, if it's possible, in the Gaza Strip, so we can overcome this need of referrals and cutting the cost by almost 90%?
Yeah, maybe just to answer, I would say there's maybe two main issues there. One is around availability, and as you said, there are different initiatives that are being undertaken to improve availability within the Gaza Strip. One related to the initiative that you mentioned with Dr. Mads, and also with support of obviously all the partners in Gaza and Ministry of Health and WHO. And I think when we talk about the sort of lack of or gaps in availability, which are really long-standing for essential medicines in the Gaza Strip, yeah, availability and potentially related to production, that's not something that we've specifically addressed, is looking at production sort of goes beyond. Of course, we can support from a technical point of view and how to strengthen drug supplies, etc. But I would say one other thing to really underline, so that would be the first in terms of strengthening availability, but I would really also underline thinking about the health system as a single system, and then putting the emphasis also on distribution, and of course that relating to all of the duty bearers. So Israel as an occupying power, Palestinian Authority and de facto authority, as well as third states in the role that they can play. And really mainstreaming the concept of health inequities and the measurement of inequities, and putting that at the technical level, sort of not trying not to politicize the issue of inequalities within the health system. But I think, yeah, I mean, long-standing structural barriers that you've mentioned relating to occupation, of course, we are trying our best in terms of the advocacy that we do with all the different duty bearers, but not always seeing the results that we would like to see.
Okay, thank you. I think now we can have a comment from Dr. Bassam Abu Hamad.
Yes, thank you, Dr. Khamis. See, regarding drugs availability, since 2000 till now, people with NCDs at Ministry of Health, because of lack of drugs. They receive their medication for 2 weeks only, which means that patients should come to the clinic every 2 weeks to receive medications. And most of the cases, the medications are not available, and I don't think this is logic. And in West Bank, they receive the medication every month, and at UNRWA sometimes with the controlled condition, they give medication for 2 months, sometimes even for 3 months. So I think the issue of shortage of medication, this is even before COVID. Only 2 weeks ago, the Ministry of Health in Gaza, they changed the policy and they started to give the medication for people for 1 month, assuming that there are medications. In response to the question before, I think, yeah, in emergency situations like in epidemics or even during Israeli aggressions, and shifting to emergency usually at the price of other services. I think there should be more of a system thinking approach, which is not a common line of thinking and thoughts. So whenever we design a responsive plan, that response focuses on the emerging issue like Israeli aggression or epidemics at the price of other services, like during wars and aggressions, more maternity deaths occur, so more other services are suspended. And this also applied to the epidemics, for example, to the COVID-19. Yeah, epidemics, like we noticed that the hospital occupancy rate is less during COVID than before. Cardiac catheterization in certain months reached up to 10% of what they used to do before. So I think it's very important for any emergency response to be balanced, and also to consider the other services and NCD services and other essential services should be part of the response, and the response should take more of system thinking approach, looking to the different parts and different components and ensuring that people have access to essential services, and any emergency response plan should not be at the price of other basic services, because the anemia could be more dangerous than the bullets or the injuries. Yeah, the heart disease could kill people more than the COVID. And we notice from the statistics that we can conclude, or at least personally I can conclude, that the Palestinian healthcare system in West Bank and Gaza overreacted to COVID-19 at the price of other services. Yeah, so the response for COVID was great. However, it did not really consider the other essential basic services that should be provided to people. There was overreaction to the pandemic, to the epidemic. Over, Dr. Khamis.
Ben, I just, sorry for interruption, but I have a friend of yours here sitting next to me. She's Rachel Coughlin from Australia. And she just wanted to say hi. Alongside, we have a group of British friends who are joining us from the UK. And they are all sending you their greetings here. They are Dr. Rachel Coughlin from Australia, Dr. Moira Lang from Scotland, UK, and Dr. Martin from Scotland. So they're all happy, and actually they were teaching our students and seeing our patients, and they wanted to attend with you, yeah. But they were doing a lot of work with our patients and our medical students and doctors, following NCD patients as well. So they're mainly working in cancer care and helping to help patients who cannot go abroad. So now they are stationed in Turkish Palestinian Friendship Hospital here in Gaza, and they are conducting training in palliative care and pain management.
And we're just about to go and have a WH.
يعطيكم العافية.
يعطيكم
I'll let you
العافية.
get back to your panel.
Actually, now they're moving to meet Dr. Abdel Nasser Sobo from WHO in Gaza. Yeah, so they're wishing you all the best in your meeting. Just yes, and they're sending greetings to all our friends, Graham, Colin, and all friends from the UK and elsewhere. Sorry for cutting the discussion.
Have a good session.
Yes.
Bye.
Okay. Do we have any further questions for our speakers?
Dr. Khamis, there is a question, I think, from Dr. Haytham Idris. I forgot to answer.
Yes, please.
So it's about the barriers preventing building settlements like housing for refugees in or outside Palestine. So I think that this is in order to prevent the increase in housing in refugee camps. I think that this issue is kind of, I think, political, because it's been around like more than 73 years of immigration, and like refugees live inside West Banks and like inside and around cities in the West Bank. So we can say the permanent solution is that they live in their own cities, like in Akka, Haifa, Yafa, etc., and other places. But I think that like how to prevent, I'm not sure we can prevent this, because with time, like population gets more, and it gets like it's overly dense, as we saw like in refugee camps in West Bank at least. So it's I think it's not an easy issue to solve, or to solve like this, but I think this is more political.
Can I comment on this, Dr. Khamis? See, refugee status is more of, it's part of the political identity of the people, and the ultimate solution, as my colleague Dr. Lama mentioned, is really to realize their right to return to their original villages and cities from which they were forcefully uprooted. So they did not migrate. Indeed, they are forcefully displaced from houses and their cities. So I think the ultimate solution is to ensure that their right to return is being realized. However, till that is being achieved, I think it's important to maintain dignified life and ensure that people have the basics. But ultimately, I think is not to build houses or to let them live in other countries. Rather, they should return to their original cities in Palestine. So this is their basic right that is guaranteed by international conventions.
Okay. Thank you, Dr. Bassam. Any further questions from our dear friends in the UK, Dr. Akhi Ian, Professor Colin, Dr. Colin, Jennifer? Any comments? Any addition, Professor Graham? Yeah, here we have a comment from Haytham Idris saying, why can't we use the people in refugee camps as a bargaining card? I'm not a politician, and they don't know how to use them as a bargaining, because they have the rights to return to their homes, and they have right to dignity, and that's the basic right as approved by United Nations.
Yes, exactly. I'm neither a politician myself, but as you said, Dr. Khamis, like they have the right to live in their home country as any other person, and that's why we focused on our study on them, because maybe their needs should be understood, and their needs should be taken into consideration even when making plans and when making decisions such as those during the pandemic, the decisions made made during the pandemic. So it was good, but it would be better if it could took into consideration the needs of the refugees and the context of like being a refugee in a refugee camp. Because, for example, the lack of commitment came because of their needs increased as the needs increased for everyone, I think, because it was a special situation like the COVID. So their needs increased, and they have it was like a burden on them, the whole situation. So they could not commit to, for example, to lockdowns and to stay at home because they need to work in order to have an income, because there's no other alternative source. So that's why maybe like it was very important to focus on this group of the Palestinian population, since they are important.
Okay, thank you very much. And here I need to correct because I was alerted by Haitham Idris that he meant that we cannot use them as bargaining cards. Yes. Here I give the Dr. Jennifer to give a comment, if she will. Yeah, please go on.
Thank you. I think these presentations this morning are really fabulous. I mean, there are issues that have come up in the very wise comments and questions regarding, you know, sampling and scope of design and aspects relating to, we just hit on some politically at the end, but it does seem to me to potentially give a very good picture of the response to COVID in vulnerable populations in Palestine. And I would say Gaza, completely vulnerable populations, and then in the refugee camps in Area C. I thought this scope was really good to have in one session. And I'm wondering if this goes to you, Dr. Essie and Rita and others, Graham, whether we should think about some sort of summary or overview paper about what we understand to be the Palestinian government responses to COVID throughout, because these data cover many parts of Palestine. I know that the literature is beginning to accumulate. I can't speak for Jordan so much. I know it's beginning to accumulate for Lebanon. And this is a very important insight into our collective part of the world, that is Palestine. So it's just a question. I know it would involve some work, but not an extraordinary amount of work, since the presenters have already prepared very good presentations and perhaps papers.
I totally agree with you. I totally agree with you. So it will have a comprehensive representational picture for whole of Palestine. What was the response for whole of Palestine? And I think it was a good way that both sides of our Palestinian territories were cooperating in this field, especially in COVID-19. So we have, through WHO and internationals, we had some sort of a similar guidelines of the management, and we have regular visits between both sides. Yes. So I agree with you that we need to come up with a paper that represents Palestine as a whole. Yes. Yeah, I think we have Dr. Cullen. Dr. Cullen, please. Yes, yeah, just unmute.
The issue of violence against women.
Okay, go on, it's fine.
Yeah, can you hear me now?
Yes.
Okay. The issue of violence against women is a complicated issue. I think there has been while it's worth considering, but I think we need to consider it given an alternative framework from the standard Western, in fact, Anglo-Saxon one, where one, it's men hitting women for no reason or whatever. And I know you would, that's not what you're thinking. I know that, but I just wanted to say, and two, that violence against women is a chronic situation where women are always without power, Palestinian women, and that is not true. One, there is a cycle of power where at first Palestinian women are weaker, yes, because of patriarchy, etc. But then once they hit their 40s, and especially when they have male children, they hold so much power at home. I can't even begin to tell you. And by the time they're 50s and 60s, they are ruling at home. So that's one point that you need to remember, I think. The other point that's very important is that we have here what we noticed, I noticed, which I call the paradoxical protective effect of patriarchy when it comes to violence against women. Because here, it's true, this is not, I'm not condoning, I'm trying to explain. I think we should address the issue of violence against women at home and outside. But at the same time, I think we need to recognize that when it comes to the political violence in our country, it is men who are exposed a lot more than women. It is men who have to brave the checkpoint, who have to make ends meet, etc., etc. And that's what I call the paradoxical protective effect on patriarchy when it comes to violence against women. I'm not trying to undo the violence that women experience. I'm just saying that there's something wrong with the framework that is Americocentric, if you like.
Thank you. Thank you so much, Dr. Rita. Thank you. Do we have any further questions, any comments? I think we have 2 minutes more. 2 minutes. I think, Graham, yes? Do you want to comment?
I put my hand across the screen and you thought I was wanting to comment.
Oh.
But it's a bit like being in an auction room and buying something by mistake. I'm just interested in Jennifer's idea of writing an overview article of these presentations about the effect of COVID, not just because it would illustrate how the system had coped with COVID, but it would also illustrate the fundamental difficulties under which the system organizes. And it would be a much lesser task than the original Lancet series, but it's still quite a big ask in terms of who would do it and what resource they would have to do it and where it would be published. But point taken, we'll take it to the steering group and see what we can do.
I think we have one last minute. We don't have any further questions. Then if we don't have any further questions, I just like to reiterate my thanks and gratitude for the 4 speakers in this session. Your talks were very informative, comprehensive. It covers COVID-19 response in Gaza Strip, in West Bank, in refugee status, NCD management follow-up, and also NCD management in Jordan. So I'd like to thank you in the name of the steering committee of the Lancet Palestinian Health Alliance and the name of every individual attending this conference. Hope to see you next time face-to-face. And now we let you go for a break, and please come back to your to this online session before 2:55.
Good afternoon, everybody. I'm really happy to be in this session, in the 6th session of the 12th conference of LPHA. In this session that will be tackling the research regarding cancer in Palestine. We will have 2 speakers in this session, and And in this session, you will have two types of research. One is regarding development of palliative care program in Palestine. And the other one will be knowledge assessment of knowledge of the breast cancer symptoms by awareness by women. But before that, allow me to remind you with some issues. The first, I will ask you kindly to be muted during the session. And the second thing, to prepare your questions. And you also can pose these questions on the chat side. And then we will be taking your questions immediately after we finish the presentations of the two presenters. I will start introducing the first presenter, Dr. Hammouda Abu-Odah. Hammouda Abu-Odah is a nurse from Gaza, and he's currently a postdoctoral fellow at the Hong Kong Polytechnic University School of Nursing, and he has earned his PhD in transitional supportive and palliative care. And Dr. Hammouda is also a Palestinian representative of the WHO Palliative Care Network. His presentation will be about exploring the factors and needs associated with the development of a palliative care program in Palestine. So I think we can move to the recording of the presentation.
Bismillahirrahmanirrahim. Thank you so much for giving me the chance to present my topic. And my topic is an exploration of the factors and need associated with the development of palliative care program into the Palestinian healthcare system from different key stakeholder perception. And this is the outline. This is the outline of my project. As you know, that palliative care is considered one of the most holistic and appropriate approaches to provide specialized care for patients with a chronic illness at the end of life care. And due to the transitional demographic change and the increase of the life expectancy, the need of palliative care has increased, and the application of this approach is needed to be adopted and integrated into the healthcare system. The integration of palliative care servicing into the mainstream healthcare system and national policies are identified as a core foundation for palliative care development. The WHO called for implementing policies to ensure that the palliative care is integrated into the national healthcare service. Many countries around the world have responded to the WHO calls by using different strategies. However, others are still struggling with the introduction of PC into the healthcare system. There is so much more to be done in countries where these services are still largely inaccessible or unavailable. Despite the significant benefits of palliative care approach, only about 5 million out of 4 million patients with life-threatening illness in the world receive palliative care services. And most of these services are available and provided in high-income countries. And the majority of palliative care required PC live in low and middle-income countries where these services are not available. Some action measures have been undertaken by the WHO to promote and integrate PC into the healthcare system of low and middle-income countries. These measures face many obstacles during the implementation. Unavailability of palliative care service in most low and middle-income countries seem unacceptable given the importance of palliative care service to patient, their families, healthcare system, and healthcare professionals. We did two systematic reviews to identify the gap. And the first was about the challenges in the provision of palliative care for patients with cancer in low and middle income countries. And the second focus on lessons learned from countries that have introduced palliative care into their national healthcare system. From these two reviews, we identified that high-level documents from governments or large organizations and non-governmental organizations focus on development of PC strategies. No research studies have been done focusing on need assessment and planning before the development of PC program into the country healthcare system. So based on the previous framework, the WHO and the socio-ecological model framework, we come up with the three main components that should be added before development of palliative care: policies, education, and implementation. So in our research, we adopted the multiple method research design that focus on three main separated studies. The first study focused on the unmet needs of patients, and the second focused about the educational needs of healthcare professionals, and the last one focused on policymaker perspective about palliative care. So the first study focused on identifying the unmet service needs of patients with advanced cancer patients. In this study, we adopted a cross-sectional design. We focus on patients in stage 3 and 4, and patients who are treated at hospital, at Shifa Hospital and Roba and Gaza Hospital. This is the instrument that we adopted for assessing the patient need. We focus on unmet needs, physical, emotional, quality of life, and spiritual well-being. In our study, we found that almost all of the patients experience unmet needs. And the prevalence of unmet need is significantly higher than those reported in earlier studies that range their unmet need between 40 to 72. And the high prevalence of unmet need attributed to the many explanations that one of them that Gaza Center are not well prepared and equipped to deliver advanced cancer service like palliative care and target cancer. The Palestinian context, scare of financial resources, limited infrastructure, and political division play also a role in high prevalence of unmet need. Most of patients experience high level of psychological distress, and this is attributed to the shortage of healthcare professionals in Gaza that obstacle them to provide a comprehensive care, and of course to the insufficient knowledge and the training of the healthcare professionals to deliver effective palliative care and symptom management. And 78% of the patients experience high level of distress, and this explanation is attributed to the unavailability of psychological support services in the cancer care center in the Gaza Strip. Although there were no spiritual care services available in Palestine in the Palestinian healthcare system, patients have robust spiritual well-being, and this is matched with other studies conducted in Arab and Islamic countries. So we conclude that the high prevalence of unmet needs support the argument that there is a need to develop palliative care program within the healthcare system. Patients have a greater need for different type of service, including physical, emotional, self-management service, which should be offered within the healthcare system, particularly within the routine care of cancer care. The next study focused on assessing the educational and healthcare system related issues from perspective of physicians and nurses. Of course, we adopted the same of previous study. We adopted a cross-sectional quantitative design. We targeted nurses and physicians who work at oncology and medical department at both hospitals, at Shifa and European Gaza Hospital. And this is the instrument that we adopted. We focus on the palliative care knowledge. We focus on the attitude of the healthcare professionals toward end of life and toward care of dying. And we also assess the healthcare system from their perspective. So we found that healthcare professionals had insufficient knowledge about palliative care, but they have high-level knowledge in the palliative care philosophy. Healthcare professionals reported positive attitude toward end-of-life care and care of dying. And these results match with those reported in the previous studies conducted in Palestine, Qatar, Turkey. However, they contradict with those reported in China and India. And the positive attitude may be justified to the culture and the religious belief of the Islamic healthcare professional. About half of the healthcare professional attended pain and symptom management and communication skills educational session. However, their knowledge is still low, and this might be attributed to the content of the educational session they attended or to the length of the educational session. Unwillingness of patient family talking about death was the main barrier. Talking about death may be influenced by families' view of death, religious belief, and cultural background. Despite the strong Islamic faith, patients and their families unwilling to talk about and to discuss death-related issues. And this is the factor associated with the professional knowledge and attitude. So we conclude that Palestinian healthcare professionals had insufficient knowledge about PC, particularly pain, dyspnea, and GI problems. Significant factor influencing professional palliative care knowledge and attitude was educational level and the previous training. Integrating formal and informal educational about PC within the care service and the health curriculum is a priority. Educational and training program should be comprehensive, covering the basic and advanced palliative care principle. The positive attitudes of professionals in this study should be considered as an important factor to integrate PC program into the healthcare system. And health education program. So for the third study that targeted policymaker, the decision and policymaker perspective about palliative care. So this study aimed to comprehensive understanding and to explore the policy-related issues from decision and policymaker perspective before development of palliative care program within the Gaza healthcare system. And we adopted qualitative descriptive design in this. And we targeted policymakers that who have a role in the healthcare system and who are responsible for making executive and legislative decisions about matter-related healthcare system, such as duty head of the pharmacological and medical supply, duty general director of nursing, and other representative policymaker. And we include 12 participants in this study. And this is the sample of the interview guide. So in this study, we generated 4 main categories: nature of the current healthcare service, potential benefit of palliative care, the challenges of the provision of palliative care, and the consideration for palliative care integration into the healthcare system. So we can conclude that most healthcare services provided to Gaza patients are often fragmented and limited to the symptomatic management. And the study finding align with those reported in countries with limited or fragmented palliative care services. Fragmented healthcare services may negatively influence of the patient outcome. Almost all of advanced cancer patients in Palestine experience high prevalence of distress and poor quality of life. So integrating PC within the healthcare system is one of the main recommendation mechanisms by the WHO to provide the optimal care for patients and their families. There are no services for supporting the family of cancer patients. Lack of service have the subsequent impact on their family and their daily living activities. So addressing the need of family are essential, especially who preparing the loved one for death. Family are required to handle their psychological and emotional distress, patient care, and concern about the future. So several challenges to PC provision in Gaza Strip were identified in this study, and these identified challenges are matched to what have been documented in high-income countries and low- and middle-income countries. So insufficient palliative care knowledge among professionals, lack of trained PC workforce, and limited funding were the main challenges. In Palestine, the low level of knowledge of healthcare professionals is attributed to the novelty of palliative care, as reported by participants. It might be also attributed to the cultural barrier, language, which is considered a new emerging barrier to PC in this study. So we conclude that the provision of PC into the healthcare system receives greater attention from Palestinian decision and policymaker. However, the development of PC service is still so far low because of the significant challenges obstacle to the development of PC. So integration of PC into the Palestinian universities' education curriculum as a compulsory course and establish high degree program in PC to overcome the shortage of PC specialists is required. Development policy aligned with the national law could help enhance healthcare service to patients and their family and resolve several challenges. So this is the final finding that come up through the 3 studies. So based on the 3 studies, we come up with the outlines of activities that will guide in the development of PC into the existing healthcare system. So we need to focus first on the setting appropriate palliative care policies. And these policies should cover the process of palliative care provision into the healthcare system, ensuring the continuity of care, ensuring equitable access to palliative care, ensuring the support of financial and insuring mechanism, identification of the resources to support the provision of palliative care. And then we need to enhancing the healthcare professional and educational training. So the government and Ministry of Health required to establish an educational steering committees for palliative care. And this committee should be responsible to develop strategies with the timeline table in how to enhance professional knowledge and training in the upcoming years. Then we need to access to pain relief and palliative care medication. The Ministry of Health should determine the minimal essential list required for palliative care based on the WHO, the essential medicine list. Ministry of Health should clearly state the intended use and the authority of the list to all. then we can set up palliative care services. In Palestine, it's important to focus on a hospital-based approach. In the long term, palliative care should be implemented into the primary and secondary care. Government should also be considered home-based care for patients at end-of-life care. And of course, we need to ensure the equitable access to care. So based on our studies, we mentioned that we need further studies to come up with a full picture about palliative care in Palestine. So we need to focus on family need. We need to focus also on the general public perspective about palliative care. It's important to focus on the general public awareness, and family need should be taken into consideration in the upcoming research. We need to focus also on pediatric PC, as this study focuses on adult palliative care. So we can conclude that almost all of advanced cancer patients in Palestine experience moderate to severe unmet supportive care need and high psychological distress. The high unmet supportive care need are attributed to the insufficient knowledge and the training of the healthcare professional about PC. High unmet need obligate Ministry of Health to incorporate physical, psychological, and self-management services within the routine delivery of care, have the potential to address patients' care needs and identify patients who need urgent help and assistance. Setting policy and laws for the integration of PC into the Palestinian university educational curricula as a compulsory subject is essential to enhance professional knowledge, which will benefit the patient and their families. Collaboration with national and international partners to overcome the challenges of PC provision and implement PC into the Palestinian healthcare service. Thank you so much for your attention.
Thank you, Odi, for this important study and also for your presentation. And I will suggest that we move immediately to the second presenter. The second presenter is already is Roba Ghithan, and Roba Ghithan is an MD, graduating from Al-Quds University, and currently she is doing her internship at the Palestinian Medical Complex in Ramallah. And the studies she is going to present on behalf of Mohamed Elshami and the research from Cleveland Medical Center in Ohio, United States, and also a group of researchers from Gaza and the West Bank. And her presentation is entitled Women's Awareness of Breast Cancer Symptoms, a National Cross-Sectional Study from Palestine. So let's go to the recording of the presentation first.
Assalamu alaikum, everyone, and thank you for your special invitation to Lancet Palestinian Health Alliance. I'm Dr. Roba Ghithan. I've graduated from medical school from Al-Quds University in 2021, and it's such a pleasure for me to present our study, Women's Awareness of Breast Cancer Symptoms, a national cross-sectional study from Palestine. And special thanks for Dr. Mohamed Elshami and Dr. Ibrahim Salibi, as well as Dr. Mohamed Sir. For disclosure, we don't have any relevant financial relationships to disclose. Starting with our introduction. First of all, why is it important to do such a research? Breast cancer is the most common cancer among females in Palestine, and it is the second highest mortality rate among cancer patients. Breast cancer is highly treatable if detected early through both screening programs and raising awareness of some symptoms of breast cancer, which promote women to present early to healthcare centers, and which is more important in such low resources countries as Palestine. Also, low awareness of breast cancer symptoms and the availability of screening programs were mentioned in recent previous studies in Palestine. Our aims were assess the awareness level of breast cancer symptoms among women in Palestine, and compare the awareness level between the two major areas in Palestine, Gaza Strip and West Bank and Jerusalem. Third, identify the factors that are associated with good awareness of breast cancer symptoms. And for methodology, we used cross-sectional type of study that was conducted from July 2019 to March 2020. And we used convinced sampling to recruit women that met our inclusion criteria from data collections, which were governmental hospitals, primary healthcare centers, and public spaces. The exclusion criteria were any female younger than 18, all non-Palestinian women, and any women that interact or work or study in any medical field, and visitors or patients of oncology departments or oncology clinics. For data collection, we used the modified version of breast cancer awareness measure after translated into Arabic, and using the electronic COPA toolbox, and it was conducted in a face-to-face interview with the participant in a private space. For analysis, we used the multivariable logistic regression to examine the association between recognizing each breast cancer symptoms and participant characteristic. To summarize our results, we have approached 6,269 participants, and at the end, we have included in the analysis 5,257 questionnaires after exclusion, the ones that didn't meet the inclusion criteria, and the ones who had missing data. The response rate was 87% in total. This figure shows the awareness level of breast cancer symptoms among participants. The figure in the right shows that there were 42% of participants that showed good awareness in total, and 48% that showed the fair awareness, and only 10% showed poor awareness. The figure on the left shows a difference between Gaza Strip and West Bank Jerusalem. We can see that participants located in Gaza Strip were more likely to show good awareness, and participants located in West Bank and Jerusalem were more likely to show fair awareness, and there were similar percentages of participants showing poor awareness, where poor indicates that the participant only recognized 0 to 4 symptoms out of 13. The fair indicates that the participant recognized 5 to 10 symptoms out of 13, and good awareness where indicates that the participant recognized 10 to 13 symptoms of breast cancer. And the breast cancer symptoms were categorized into 3 major categories: breast symptoms, nipple symptoms, and other symptoms. Breast symptoms contains different symptoms, including a lumbar thickening in the breast, pain in one of the breast or armpits, puckering or dimpling of the breast skin, redness of the breast skin. Nipple symptoms included discharge or bleeding from the nipple rash, change in the position of the nipple, pulling in of the nipple, and other symptoms included lumbar thickening under the armpit, changes in the shape of the breast or nipple, changes in the size of the breast or nipple, unexplained weight loss, and extreme generalized fatigue. Out of all these symptoms, the most identified symptom was a lumbar thickening in the breast, which in total there were 93% of participants that recognized this symptom. And there is a similar percentage between Gaza Strip and West Bank and Jerusalem. The second most common symptom to be recognized was a lumbar thickening under the armpit. Both symptoms are related to lump, and here it is 84% in total in both areas, and also here there is similarities in between Gaza Strip and West Bank and Jerusalem. The least identified symptom to be recognized was pulling in of the nipple, which has only 51% in total that recognize this to be a breast cancer symptom. We can see there was 55% of Gaza Strip participants who recognized it right, and only 47% in West Bank and Jerusalem who recognize it right. This table shows the symptoms related to breast, which shows the redness of the breast skin to be the least identified symptom. For nipple symptoms, that in general were the least common symptoms to be recognized, and other symptoms including unexplained weight loss and extreme generalized fatigue, both of them were the least identified and least linked to breast cancer. In this plot chart, and by using the adjusted ratio with 95% confidence interval, we see the significant association between the participant characteristics and having good awareness, which are being 40 or older, having post-secondary degree and higher, knowing someone with cancer, and being in hospital or primary health care centers when the collection were established. And that may indicate the more interactive a participant with the healthcare system is more likely to have good awareness. Our future directions are that interventions should adopt more and different strategies to aim to maximize the outreach of women, especially those in underserved areas. The running of healthcare education activities should be in coordination with the mobile healthcare clinics of the Palestinian Ministry of Health, for which that underserved areas should be easily reached, and the educational programs should include the least known breast cancer symptoms, and to emphasize on the prognosis of presenting early with any of breast cancer symptom and its impact on improving survival. The limitations of this study was using convenience sampling may potentially limit the generalizability of the findings. Participants who didn't experience actual breast cancer symptoms and looked at their perceived knowledge that we didn't include these population, and the recognition of breast cancer symptoms was assessed, while it might have been helpful to assess the recall of these symptoms as well. Our conclusions are that there are less than half of participants that demonstrated good awareness of breast cancer symptoms. Participants in Gaza Strip were more likely to demonstrate good awareness than participants in West Bank and Jerusalem. And the factors associated with good awareness were being 40 years or older, completing a post-secondary education, knowing someone with cancer, and visiting hospitals and primary healthcare centers. And that's all for this presentation. Thank you.
Thank you, Roba, very much. Very interesting also a study. And I will return back to the audience and to see who have a question or a comment. I didn't see any questions in the chat box, but I'm sure that you have a lot of questions. Meanwhile, I don't know if Oda would like and Rola would like to add anything?
Yes. Assalamu alaikum.
Assalam.
Dr. Motassem, thank you so much for moderating this session. Yeah, I would like to mention that for, I think, Miss Mona Khalid, she mentioned that there is, she's work in Sanad Association and she's going to do something in Gaza with Al-Awan Wal-Amal Institution, which is very important. Actually, I started my PhD studies. This is a part of my PhD studies in 2018. And during that time, I worked with some national and international organizations to convince them to move forward in the development of palliative care, because one hand it's difficult to move further. So I'm so happy to connect with them and to present more in detail about my previous studies that come up with the assessment of patient with advanced cancer, the needs, policymaker perspective about palliative care. And of course, now I'm so happy that also team from UK, from Scotland, they are starting now teaching the medical student at Islamic University about palliative care awareness, because palliative care awareness or knowledge for healthcare professional is one of the many challenges in Gaza Strip. And one of the major issues that we found during interviewing the policymaker, that one of the policymaker mentioned that many of sessions that have workshop that have been conducted in Gaza about palliative care. But one of the issues that some of the physicians and nurses that who attended the session that cannot understand comprehensively about the topic, because most of the experts that come to Gaza, they are speaking English, which make barrier for them, which is one of the main issues that we highlighted in this study. Language is one of the important issues, especially for Arabic native speaker, especially nurse and physician. We know that we study in English, but when we talk about something new, I think it's much better to involve the local expert to present the topic about palliative care. So that's all from my own side.
Okay. Can I ask you something? If you have an idea, Hammouda, you already mentioned some data about how far patients with oncology are receiving care, palliative care. Do you have an idea about that in Palestine? How does it happen? What's the proportion of patients who are receiving such a care in Palestine, and what kind of and the availability of the services? What kinds of health institutions in Palestine?
So you mean what happened about palliative care in Palestine?
Exactly.
In terms of palliative care, just what have been conducted. Actually, Palestine is ranked according to the WHO and the international organization. It's moved from the capacity building level to specialized palliative care, which means that palliative care have introduced in some health institution. But this what happened in the West Bank, in the another part. But in Gaza, there is nothing have been done. Just only what have been done recently, that Turkish Palestinian hospital, they mentioned that they add some what is called the idea that there is a palliative care service, but already in the reality there is no palliative care service. They are trying to develop palliative care service since 2010 until now. Actually, what have been done so far in this, just only training, and not that organized or systematic training. Some international institution, some professor from UK, from Scotland, they come and they produce and they conduct and launch it workshop or some scenario and then go back. So there is no systematic follow-up. What we are going to do, at least for the upcoming 5 years, in the Ministry of Health in Gaza, they mentioned that palliative care in the strategic plan in the upcoming 5 years. But what have been done? Nothing at this stage. Just only what have been done in Gaza. They develop palliative care committees, and these committees just only focus on they are trying to develop palliative care guidelines. But why not to look for Jordan or West Bank? They have guidelines. So why not to adopt this guideline and adjust this guideline with the Gazan context? So this is what happened so far, and just mostly about capacity building development.
Okay, thank you. I don't know if Mona, if you would like to pose your comment, or Mona. Okay. Okay, I think we have a comment from Ian. It's for Rola. Rola, if you have any comments, if you can also make a response to Ian's comment on the issue of screening or rapid diagnosis assessment of women with cancers in Palestine. If you would like to respond to that comment, any question. You have a question from Ian saying that faced with the choices, Ian, would you like to pose your question? I can see you, but I can't hear you. You need to unmute your mic, Ian.
I can't do it. Now I can do it.
Yes, yes, please.
Thank you for the invitation, and thank you to Rana for the presentation. So my question was, if you're faced with the choice of either implementing population screening for breast cancer or ensuring rapid diagnostic assessment of women with breast symptoms, which would you choose as having priority?
Roba, would you like to respond to the question?
Yeah, I'm Dr. Roba. I'm speaking. Do you hear me?
Yes, I can hear you.
Okay, thank you for this such a great question. Actually, for rapid diagnosis, either by picking up with the breast cancer patients, either by screening methods or by early presentation, those two types of that would lead to an early diagnosis for patients. For specifically for Palestine, that it's considered to be low resources country and doesn't have such financially wise suitable cost to implement an early diagnostic other early diagnostic approach. We more by literature and by the situation here, the early diagnosis by force or leading patients and encourage them to an early presentation by their recognition symptoms, that would be more financially acceptable for society or for the government than to implement or to give more resources or to give more finance to implement in screening programs. So an early presentation by recognition of symptoms to early diagnosis, that would be more suitable, such according to the situation right now in Palestine, than the other choices.
I'm very reassured by your response to my question, and I hope that you can, in your presentations of your work, if you can make that point, the point that you've just made with your answer to my question, if you could make that point as a regular component of your presentations, I think that would be in the interests of the women of Palestine. So I hope you'll do that. And I should mention that the doubt about the relative value of population screening, even in rich countries like Britain, raises its as an important issue for consideration. The important thing, it seems to me, and I'm reassured, as I say, by your response, is that women with symptoms should be taken seriously and responded to promptly, and it made it easy for them to refer themselves, because it's for many women a very embarrassing thing to be explicit about. So thank you very much indeed for your great answer to my question.
Thank you.
Thank you.
Please go ahead.
I would like to add a point. Our paper is about detection of their awareness, like of breast symptoms, but also in the literature, there's also there's the awareness also by the availability of the screening programs. So there's too many parts to take, and yeah.
I think you may find
maximize the benefit of this research as well as.
Okay, I see Mohamed Raed, who is also the collaborator in this research, raising hand. Mohamed, if you would like to make any comment, please go ahead. Mohamed Elshami, you are already muted. Mohamed,
can you hear me?
Yeah, yes, now, please.
Sorry, I couldn't unmute myself at the beginning. Thank you so much for giving us the opportunity to present our work here today. So just a follow-up comment. Actually, we're working on a project looking at the association between the awareness level and the anticipated time to seek medical advice for a possible breast cancer symptom. Some leaking results from that project. So we found that having or displaying a good awareness is associated with a shorter time actually to seek medical advice in a Palestinian Ministry of Health facility. So I think that's related to Sir Ian Chalmers' comment. And I totally agree about the importance of handling and treating patients as soon as they present with their symptoms. But for me, I think in the context of Palestine, especially in Gaza with the limited resources, like very limited resources in terms of diagnosis and treatment, focusing more on early presentation, as Roba said, mainly I would say by screening should be prioritized. So one of the goals actually from our project, Cancer Awareness in Palestine, was to promote this early awareness, early detection, sorry, and then so if we couldn't diagnose cases at the beginning, maybe we could potentially prevent actually the occurrence of breast cancer. So for me, prevention is better than cure. That the perfect scenario for this quote is Palestine, because for breast cancer, we are very limited in terms of treatments. Say for example, here in the U.S. You have many options to treat triple negative breast cancer, but in Palestine, I'm not aware of like many options for that disease. You can say for HER2 new positive patients the same, like Herceptin is not that available. So I think the best approach to deal with breast cancer in Palestine is to prevent it. If we couldn't, we hope to improve early diagnosis and early presentation.
Okay, I think also we have a question from Mads Gilbert. Mads, please go ahead. You need to unmute yourself.
There I am. There, thank you.
Yes, welcome.
Thank you so much, my friends, and thank you for a very interesting presentation and discussion. I just want to point out what has been said about the limitations of treatment options in Gaza in particular, and in all of occupied Palestine. The capacity for radiation treatment, as you know, is exceedingly low. It means you have to go to Augusta Victoria Hospital in Jerusalem in order to have radiation therapy. In Gaza, there is zero radiation therapy, zero machines, meaning that Palestinian women in Gaza who needs radiation therapy for their standard basic protocol of treatment, they have to apply for a permission. And as Ben Bouquet, who spoke earlier, has shown, a large number are denied exit permit with no reason, up to 40%. And there is a significant higher mortality among them who are denied exit to have treatment outside of Gaza, which I would call a sort of a very stark and unacceptable example of medical apartheid. If you look at 5-year survival for women with breast cancer in Norway and in Israel, I think it is around 97%. In Gaza, it is around 62%. So this is a graphic illustration of where we need to focus the advocacy and the struggle to have a decent cancer program for women and for all other cancer patients in Gaza. It's not enough to have screening if you don't have proper treatment. So again, I think we need to address the brutal reality of having cancer in Gaza, because either you're not allowed to go out for your radiation therapy, or there may not be capacity enough in Augusta Victoria. I mean, the colleagues in Augusta Victoria are doing a fantastic job, but they only have the resources they have, and they are going to serve West Bank and Gaza. So let's not forget about the structural violence inherited in the cancer treatment for the Palestinian people. It is a scandal. Thank you.
Thank you, Matt. I think we can have one more question, very quick, one or two questions. Any questions? Okay, I think we have to recognize the importance of the two studies in really focusing attention to very important issue regarding to the oncology services and the need for, you know, the continuation of services from diagnostic to treatment and to palliative care. And I think our colleagues were, you know, successful, have addressed real challenges in terms of, you know, knowledge, but also availability of services, and challenges also for considering this kind of development in the healthcare system on the strategic level. I would like to thank both of them for their excellent presentations, and I also I also would like to ask you kindly to remain with us for the next session that will be led by our colleague Huda Zurayk from the from Beirut, from Lebanon. And I would like to thank you all. First, to thank the speakers for their contributions, and the presenters also, and also you, the audience, for your interaction and attendance. And I think we can you can have 1-2 minutes break before that.
Okay. Good afternoon. I'm very happy to be with all of you in this session. This is a specially solicited session that is addressing the broad question of where we are from the cause of social justice for Palestinians, with a view to better understand their current predicament and how these impact their health and well-being. Our first speaker in this session is Dr. Ghassan Abu Sitteh. Dr. Ghassan looks at the unfolding lives of Palestinians who were forced to flee Palestine in 1948 to neighboring countries, where their lives eventually got enmeshed in the complex and deteriorating conditions of receiving countries, pushing them to further migrations and exiles. Let me introduce Dr. Ghassan before we listen to his presentation. Dr. Ghassan is a plastic and reconstructive surgeon who is currently practicing privately in London. He is an honorary senior clinical lecturer at the Imperial College University of London and a visiting senior lecturer at King's College in London University. He also maintains his position as a senior researcher at the Global Health Institute of the American University of Beirut. Dr. Ghassan is from Gaza, and he has traveled many times to Gaza under crises to help in the reconstruction and medical services. And we welcome you, Dr. Ghassan. Please, tfaddal.
Thank you very much for this invitation. So, as we all know, following a major earthquake, the affected area suffers a series of further aftershocks. And I think what I want to talk about today are the aftershocks of the Nakba earthquake that still shape Palestinian lives and throw up questions that, unfortunately, as a result of the political crisis within the Palestinian National Project, the Palestinian political elite or institutions are failing to understand and respond to. So as you all know, 85% of Palestine's population was expelled during the Nakba. We have to start emphasizing evidence that shows that 50% of those expelled were expelled while the British were still occupying Palestine in 47, and further 50% were expelled after the declaration of the State of Israel. In 1967 war, a further 280,000 to 325,000 Palestinians were expelled from Gaza and the West Bank. Prior to 2011, UNRWA, number of registered refugees in UNRWA were around 500,000 in Syria, around 2 million in Jordan. The registered number in Lebanon was around 450,000, although that is highly disputed. In Gaza, it was around 1,300,000, and in the West Bank, around 770,000. But since really the end of the last century and the beginning of this century, there have been major upheavals that have changed the picture of the distribution of Palestinians globally. And this has recently been highlighted by two very tragic events. The story of 7 Palestinian young men drowning off the seas of Tunisia while trying to attempting to reach Europe in a smuggler's boat, 6 of whom were from the same family in Khan Yunis, and around 40 Palestinians from Nahar al-Barid in the doomed boat that sunk off the coast of Syria, and a further 7 from Shatila, really highlight the dire situation Palestinian refugees still remaining in the Arab world find themselves at. And an indication to these further waves of migration as Palestinians try to reach areas where they can have a better quality of life. So if we go chronologically backwards, just as the economic crisis in Lebanon that has been going on for over 2 years has led to large numbers of Lebanese seeking refuge outside economically, this is also reflected in Palestinian refugees in Lebanon. Lazarini's recent statements about living conditions of Palestinian refugees in Lebanon reflect the fact that it's almost now that 90% of Palestinian refugees live in under the poverty line, and that is further driving the number of Palestinians living in Lebanon from probably what was around 170,000 to a smaller number, with all of them seeking refuge in Europe or North America, especially Canada. The war in Syria also decimated the number of Palestinians living in Syria. UNHCR had estimated around 120,000 Palestinians left Syria since 2011, but most likely the number is much higher. There are certain Palestinian factions in Syria that say just from Yarmouk camp alone, around 23,000 went to Sweden. So that reflects the number of Palestinian refugees living in Syria probably has decreased from around 500,000 prior to the war in Syria to probably by 50 to 60% decrease. In Iraq, following the American invasion in 2003, of the 50,000 Palestinians who were officially registered as refugees in Iraq, the overwhelming majority sought refuge following the American invasion and then the civil war that erupted afterwards. Before then, around 400,000 Palestinians who had lived in Kuwait found themselves evicted from Kuwait following the first Gulf War and the occupation of Kuwait by the Iraqi army, and then the expulsion of Palestinians from Kuwait. So around 400,000 became around 10 to 15,000. And many of these either initially sought refuge in Jordan, who had Jordanian nationality by virtue of their West Bank origins, or were able to emigrate to Canada and to Scandinavian countries. Ever since the 1982 Israeli invasion of Lebanon, Palestinians had been leaving Lebanon in droves, particularly after the camp wars in the late 80s. And a lot of that migration happened towards Scandinavian countries. So as Palestinian diaspora pictures change from the Arab world to more Europe, we are witnessing something new that's happening. And part of that is a denial of the expression of Palestinian identity. Germany, which is one of the worst places to be a Palestinian in, now completely equates all expressions of Palestinian national identity with anti-Semitism. So the raising of the Palestinian flag, the commemoration of the Nakba are automatically under German law considered expressions of anti-Semitism. This is despite the fact that a large Palestinian community now lives in Germany. And these two diametrically opposite currents need to be explained better. The same in Sweden, where it's estimated to be that around 80,000 Palestinians now live. So what's happening in Europe as the number of Palestinians living there increases? Well, what's happening is effectively a denial of the right of Palestinians to express their Palestinian national identity under the guise of it being an expression of anti-Semitism. So all expressions of Palestinian identity are now becoming almost not stigmatized, but more than stigmatized, criminalized under these new definitions of anti-Semitism. And this definition of new definition of anti-Semitism comes after, I believe, a new deal between the European political elite, 80% of which now lies to the right, and the Israeli establishment, where the Israelis accept to absolve the European right of its anti-Semitic origins in exchange for a joint definition of anti-Semitism to equate with the expression of Palestinian rights, or the expression of solidarity with Palestinians, or the expression of Palestinian national identity. And so right-wing organizations and parties in Europe that can find direct links to anti-Semitic origins in Europe now find themselves completely absolved by the Israeli government in exchange for this new definition of anti-Semitism, which equates Palestinian national identity with anti-Semitism. A similar process is happening in Canada, where although an increasing number of Palestinians, and it's estimated to be around 100,000 Palestinians now live in Canada, find themselves being unable to express their identity or even sympathy towards their countrymen in places like Canada. and increasingly Palestinians in Canada, although there are new generations of second-generation Palestinian Canadians are emerging, this crackdown on Palestinian expression of identity is becoming more and more acute. Similar processes are happening in all of the countries that are taking or have taken increasing numbers of Palestinians. So how can we explain these two contradictory events? These countries are taking a larger number of Palestinians, yet they are cracking down on all expressions of Palestinian national identity. So in Sweden, when a Palestinian woman from Gaza wins a mayoral election, at the same time, Sweden will move to criminalize support for Palestine and Palestinian national aspiration. But we have that in the history of colonial rule. The school system, the residential school system, whether it was in Australia or in the United States or in Canada, was always built around the idea that you can save the man while killing the Indian in him. And what I think we're watching is a similar process in Europe. As Palestinians living in Europe and North America, we have to accept that we live in the metropole of the settler colonial, the racial settler colony that is Israel. We live in the metropole that created that colony. And therefore, this strained relationship with this metropole that goes beyond an ally of Israel, but actually is a much more organic relationship between the West and the settler colony that is the Zionist state, it reflects that relationship. And we, increasing number of Palestinians, find ourselves living within this metropole and trying to understand this contradictory relationship between an increasing number of Palestinians who find themselves citizens of this metropole, while this metropole increasingly will not allow them to express any identification with their national struggle or express any sympathies with their countrymen. So Palestinians are looking for new places to try to escape and new ways of this everydayness of Palestinian resistance. And so one of the interesting phenomena of Palestinian resistance against this is that for the first time, groups of Palestinians that had come from the Palestinian refugee camps are able to reconnect with their relatives and with their kin inside 1948, because as Palestinians living in Europe, they're able to connect more. And as a kind of anecdote, I found myself in a paying respects for someone who had passed away, and he had been from Ain al-Hilwa and had moved to the UK to study in the late 70s, and had originally his family came from Al-Shajara village in the Galilee. And I discovered that during his life in the UK, he had reconnected with his relatives in the Galilee, and that a lot of the people from in the Aza, in the kind of wake that we were at, were from the same village. Half of them were from Ain al-Hilwa and the other half from inside Palestine. And so despite this crackdown on Palestinian identity, Palestinians are using these new spaces that they're created to try to reconnect as communities and rebuild communities that had been completely torn apart during the first Nakba and as a result of these aftershocks. for those of us who moved to Europe in the 80s, it's striking how actually the crackdown within open political debate in Europe is more acute now than it was in the late 80s, even though European public opinion had shifted more towards understanding and accepting the Palestinian narrative of what's happening in Palestine. And I think we have to explain this partly due to the increasing number of Palestinians who find themselves now living within Europe and within North America. And I think that increase in that attempt to neutralize any political gain that the Palestinians might have from finding themselves as active political agents within these countries is why this space is being shut down by European governments and by North American governments. Thank you very much, and I'll leave it here.
Thank you, Ghassan, for this very inspiring presentation. And I think it's a very positive note to indicate how much this Palestinian identity retains itself and the communication between people. We have seen this maybe a little among the Armenians, but not to the same way. It's a very important force in the maintenance of this question. Our next speaker is Dr. Osama Tannous, and Dr. Osama will speak to us about the situation of the Palestinians who are living inside the Green Line. He portrays their lives within an Israeli settler colonialism strategy, showing how injustices against them continue to multiply into the present. Let me first introduce you, Dr. Osama. Dr. Osama is a pediatrician and public health scholar. He is a co-director of the Palestine Program for Health and Human Rights, which is a partnership program between the FXB Center for Health and Human Rights, Harvard University, and the Institute for Community and Public Health, Birzeit University. Osama is a board member in Physicians for Human Rights Israel and B'Tselem, and a policy analyst for Al-Shabaab. Tfaddal, Osama.
Thank you, Huda. Thank you, Ghassan, and thank you for the audience and for the LPHA for inviting me. I will try to give an overall presentation about the political situation of the Palestinians inside the Green Line and how that affects their health outcomes, and maybe try to see the similarities and be in conversation with Ghassan's presentation. So I will just start with a brief introduction, talk a bit about health disparities, then go on to theoretical framework of racism and settler colonialism, how we can use them to understand the situation of Palestinians inside the Green Line, and emphasize the gaps in knowledge about us. So a brief, as you all know, in the Nakba, the vast majority of Palestinians were expelled from their homeland and they either into the neighboring Arab countries, the creation of basically the expansion of the Israeli frontier has created the geographical categories of the West Bank and Gaza Strip in that sense. And a small minority of Palestinians remained within the Green Line. So people like me and my grandparents who either remained or were expelled to Lebanon, Jordan, but somehow managed to transpass and return and have Israeli citizenship. So the Palestinians inside the Green Line between 48 and 66, there is some kind of voice in the background. So between 48 and 66, we were subjected basically to a military rule, which means that every Palestinian town, like my town Tarshiha, or like all the neighboring towns, were under strict military governance, meaning that everybody who wants to leave, either for any treatment or work or any kind of leaving the village, will need a permit from the military rule. But mainly this was a way to conduct massive land confiscation. So the vast majority of the land of Palestinians were confiscated during that period. And of course, that was a period of really terrorizing the consciousness of the Palestinians in the fear that you need to be obedient citizens and subjects, otherwise you will be punished, you can be expelled. This is the time where the massacre of Kufr Qasim happened, among other atrocities. So it was quite formative in the consciousness. Later on, important landmarks are the Land Day, which was one of the first confrontation between the Palestinians in the Sakhnin, Arabi, Deir Hanna. We call it the Triangle of the Land Day, against land confiscation that really led to the killing of Palestinians, the injuring of Israeli army and police, but it really symbolized somehow of awakening and a breaking of the barrier of fear. While the majority of land was confiscated before, this really symbolized a way where people were saying, no more, you cannot take more of our land. Of course, the first Intifada and afterwards the Oslo Agreement had a different effect on us, basically because the PLO within the Oslo Agreement somehow left the Palestinians inside the Green Line as an internal Israeli matter. Right, and later on, the second Intifada, of course, also occurred within the Green Line with the October events and the killing of Palestinians inside the Green Line and martyrhood. So all of these are kind of dots in the formation of Palestinian national identity inside the Green Line, and lately the nation-state law, which I will talk about. So how can we understand basically the features of our life within this strange racial colony? First of all, segregation. I'm not sure that, I think a lot of people have not been inside the Green Line, but more than 90% of the Palestinians live in completely segregated town. So only 10% live in so-called mixed towns, so towns like Haifa, Jaffa, or Akka, but the vast majority are completely segregated. Within the years, we went through a process of de-peasantization, meaning, as you know, in the Nakba, most of the urban community in Palestine was completely expelled, killed, or expelled. So the Nakba has kind of eliminated the urban experience of Palestinians and the urban elite. The ones that remained were farmers, but with time, Israel confiscated our land, water, and agriculture. So we stopped being farmers, we stopped being, there was no urban elite. So it was a kind of mutational growth. And at the same time, you have ghettoization. So we kind of constitute 20% of the registry of the Israeli population, but we live on 3% of the land. This is a book that I highly recommend to people who speak Arabic, and it's translated also to English. It says essays on the kind of crippled modernity, to showcase how the Palestinians inside Israel went through a process of modernity with the lack of urbanization. So basically, when you have only these small townships and how that affect the livelihood. So what can you see or cannot see when you walk through inside the Green Line? How do we look like? So this is from an app that I encourage people to look at. It's called the iReturn, and it maps the Palestinian towns that were completely evacuated in 48 in the Nakba and no longer exist. So all of these dots symbolizes towns that no longer exist, but you can click on them and see them and see how they were. that is something that you cannot see when you look at the map right now or when you walk through the street or drive, but you see these scattered Palestinian towns that are segregated and look like this, basically, because of the confiscation of land, a lack of urban planning or any form of master planning. So basically people build on top of each other, just trying to provide a rooftop. So our towns have become these kind of crowded ghettos with concrete structure with no green spaces or any features of a city. How does that affect health disparities? So if we look throughout the whole space between the river and the sea, throughout all of Mandate Palestine, we can see that Jewish Israelis have the highest life expectancy versus Palestinians inside the Green Line that have shorter life expectancy, and then Palestinians in the West Bank, and then Palestinians in Gaza Strip. Of course, this reflects also the hierarchy of the social determinants of health, so the political and social conditions that constitute most of our health outcomes, and also the access to healthcare. So somehow, if we look at this entire space as a space governed by apartheid and by Jewish superiority and Palestinian inferiority, we can try to really map these different shapes of and hierarchies. So if we look inside the Green Line, these are from the Israeli Ministry of Health publications. So if we look at the towns with the highest overall mortality rate, all of the 10 towns, out of the 10 towns with the highest mortality rate are Palestinian towns. There is only one here, Dimona, which is a poor Jewish town in the south. But and sometimes it's double of the national mortality rate. So there is huge disparities in health outcomes. And if we look at mortality from heart diseases, so while the national average is almost 250 per 100,000, all of the 10 towns with the highest mortality rate from heart diseases are Palestinian towns. So all of these are Palestinian towns, completely segregated, that you can see have almost double the mortality rate. I'm just trying to emphasize the differences in health outcomes. And this is also from the Ministry of Health. So the green symbolizes the Palestinians and the blue Jewish Israelis. So from all causes of diseases, and this is the relative risk of mortality, the odds ratio. So from cardiovascular diseases, diabetes, stroke, and basically from all diseases we die more, except for suicide and dementia. Okay, so we commit less suicides and we reach a less, a higher age, so there is less dementia. And when it comes to homicide, actually, it's quite terrifying because, and you might hear about this in the news, the ghettoization has really led to kind of a crime-friendly environment where the Palestinian towns have become towns of basically communal crime. So a lot of Palestinians die from homicide, much more than Jewish Israelis, much more than Palestinians in the West Bank or the Gaza Strip or the neighboring Arab countries. And a lot of the literature basically focuses on the individual, risk factors. They try to bring it up to us, to our biology, our culture, behavior, how if we eat unhealthy food, we smoke, we don't do diet, so on, while ignoring the vast majority of factors that determine our life and have been designed by the Israeli state. So how can we make a better understanding of this? Okay, also our health mirrors a lot of the health of indigenous population. When you look at indigenous populations in North America, in Australia, New Zealand, so the same, we have much more diabetes, much more homicide, much more heart diseases, younger life expectancy. And this is from an article it's my article that should come out in a few weeks in the Journal of Palestine Studies, where I compare the health of Palestinians inside the Green Line versus the health of other indigenous populations. So we can see a very similar pattern of much higher neonatal mortality, much higher rate of mortality from diabetes, cardiovascular diseases, heart diseases, and so on. So that pattern exists, but how can we understand it? If you look in PubMed or in the other medical literature, you will find very little discussions on racism or in colonialism when it comes to the health of Palestinians inside the Green Line. You will often see descriptions of Israel as this rich European welfare state with multi-ethnic population, and it has an Arab minority, you know, this is how they call us, an Arab minority, that has health disparities or a gap that needs to be bridged. So instead of talking about race or ethnicity, let's talk about racism and how we can understand that, which has been the debate in the USA and in other countries. So racism is defined by Kamara Jones, was previously the head of the American Public Health Association, as a system of structuring opportunities and assigning value based on the definition of race, which unfairly advantages some people and discriminates against other people. And this has operated in different ways in the USA with the structuring of opportunities for whites, blacks, Asian Americans, and indigenous. This is basically the core of Zionism and the state of Israel, right? Building a system that structures values and opportunities based on racialization. As we know, race is a social construct. There is no, and it's a product of its own environment. It doesn't follow the color line. It is not about being black or white or being Jewish or Christian or Muslim or so on. In different locations, racialization operated differently. So if we look at Ireland, you know, the whole concept of racialization also among white Christian population was built on the settler colonization, of course, of Ireland, and on differences in Protestant and Catholic and so on. In the USA and in Australia, it operates differently. In Sudan and in different parts of Africa, it operates completely differently how the racial categories are created. In Israel, as Lama Tatur, Arish Sabbagh, and other scholars argue, citizenship was designed as a tool for racialization, where the settlers is seen as the natural, and so Jewish Israelis are seen as the natural, authentic citizens, and we as if aliens and guests in our own country. So even when people say that, you know, Palestinians, they have inside the Green Line, you have Israeli citizenship, you have Israeli passport, somehow you're a part of the democratic process, of course, but that has been used as a way to dominate us rather than to gain equality. So we face multiple levels of racism that is legalized and structural. It is much more similar to the USA during the Jim Crow era or apartheid South Africa than the USA today, because racism is written within the law, right? So the assignment of value, where you can live, where you cannot live, what you can work, and basically, if we look at the Jewish nation-state law, which passed in 2018, it clearly states that Israel is a Jewish state where the right to exercise self-determination is unique to the Jewish people, right? And the building of Jewish-only settlements is a value to be promoted, strengthened. So it is not, you know, like the USA or Australia or different European countries that claim to be a state of all its citizens, but then operate within different levels of racism. It's a country that upfront says, I am the country of only one racial category. And if we look at the whole, you know, all of Palestine, all of Mandate Palestine, we need to understand how this racialization, not only within the Green Line, it really determines who was, first of all, who was allowed to stay here and who had to expel, who was expelled, which was what Ghassan talked about, who is allowed to come and live here and who is not allowed, and then how these different hierarchies of Palestinian citizens in Israel, Palestinians residents in Jerusalem, or Palestinians in the West Bank and Gaza are created and produce different health outcomes. Okay, so racialization operates in a very different way than what we see in the USA or Australia, where everyone is a citizen, but you have different forms of racialization. excuse me, I have a bit of a sore throat. So, and as we know, racism affects health in multiple ways that we know or do not know. It affects our land alienation. As I said, most of Palestinians have been alienated from their land, from our ecosystem, economic deprivation, trauma, inadequate medical care, and ongoing response to trauma, to discrimination. All of this operates all together like a spider of web to produce worse health outcomes. Okay, so this is racism. When it comes to settler colonialism, as I'm sure most of you know, settler colonialism has been theorized much recently. It's a different form of colonialism where the settler aims to replace the indigenous population through the kind of elimination of the native, and not only to control it from the outside. Israel, like Australia, North America, Canada, are settler colonies where a white population comes not to integrate within the existing population, but to replace it, basically. This has been our case. There is a lot of writing on settler colonialism and Israel. But what is important to understand and distinguish that unlike previous settler colonies like Australia and Canada, where the vast majority of the indigenous population was massacred, completely eliminated, and now they are only like between 1% to 3% of the population. In Palestine, we're much more. When we look at all of historical Palestine, we are 50% of the population. A large population are refugees. So settler colonialism operated in different ways. It could not do the same large-scale massacres. So it was mainly focused on expelling and then creating these different compartments in order to create a settler majority inside the Green Line and in the settlements. And if we look at the, actually how does our reality looks like on the map? So the same, what we are used to seeing in here on the right side is the West Bank, expansion of settlements, the confiscation, stealing of lands, and so on. All of that processes happened in the 50s and 60s. So this is my hometown here of Tarshiha. Tarshiha. So the Galilee, most of the towns, were expelled, either bombed, but then we remained on small amount of land versus, and here you can see Ma'alia, like the neighboring villages, but the vast majority of land was confiscated for the building of Jewish-only settlements around us and kind of to ghettoize us. So the same frontiers, if we can imagine the frontiers in the USA that were expanding towards the West Coast or towards the South, these same frontiers were operating here within the Green Line, and then after 67, it happened in the West Bank and Gaza Strip with the taking of land, the building of Jewish-only settlements, only that this happened in the 50s and 60s. And this is from the report of Amnesty International, of Human Rights Watch. Okay, so this is basically how you would see. Jisr al-Zarqa is the only Palestinian town that remained on the coast. The vast majority of coastal towns were completely evacuated, ethnically cleansed, but then the town was surrounded by Jewish settlements. So here you can see a growth with under ghettoization that produces these differences in population density, in infrastructures, and we end up having something like this, that of course this is not a healthy environment to live in, to walk or to do sports or to to have any form of a healthy lifestyle. So basically, the Palestinians in Israel live in small geographical enclaves that are often stigmatized zone of racial exclusion, economical marginalization. They are not villages or cities, they're literally townships. Baldat. Just a moment. we have a shrinking of the living space, demographic growth, and absorption of the internally displaced. So again, almost 30% of the Palestinians who remained even inside the Green Line are displaced from, so they are not refugees because they did not cross internationally recognized borders, but they were displaced from their own towns that were evacuated into other Palestinian towns. So the Palestinian towns had to accumulate and absorb another population. So if you look at Nazareth, all the surrounding towns of Safuri and Mjaidel and so on ended up in Nazareth, just adding to the population. You had the destruction of urban life, annihilation of rural life, became landless peasants and urban dwellers and kind of impoverished proletariat. And despite having a very clear pattern of indigenous health and multiple forms of racism, when you look at a lot of the medical publication about Palestinians in the Green Line, they are often called Israeli Arabs. They are reduced to minority health in this welfare, advanced democracy. And this is really part of the fragmentation of Palestinian health into minority health, refugee health, conflict health, something that we are really trying to struggle and to write, and I think the frameworks of settler colonialism and apartheid and the structural racism allow us to assemble all of these pieces together. So there is a lack of critical knowledge production. There is, of course, some, but it's very little. There is a lot of writings about discrimination and so on, and minority health and cultural behaviors, but really nothing that focuses, very little that focuses on racialization and settler colonialism. But do not worry, we are not passive subjects. We are here, we are resisting, just like all of the Palestinian people. So these are just some photos I wanted to share. This is in Haifa during the Prover plan. We organized like massive demonstrations against land confiscation in the Naqab that really led to a lot of clashes with the police and eventually to the stop of the plan. These are a Palestinian couple in Bir'am, a town that was ethnically cleansed in 48, and people still return there, have their weddings, and celebrate Christmas over there. And try to resist and remain in their homeland. This is in the Naqab, Al-Araqib, a town that has been destroyed many times, and still people rebuild it every time. And here they've built a theater basically and do cultural activities. This is in my hometown of Tarshiha, where people commemorate the Nakba Day, Yom Tarshiha, when the village was bombed and the vast majority of people were expelled, and we held different kind of activities with the refugees of the village and kind of commemorate the martyrs and educate the next generation. So it's an ongoing struggle, like all of the, I think, Palestinian struggles. And thank you. You are on mute, Huda. We can't hear you.
Okay. I was saying that it was a very insightful presentation, and although sad and painful, but it still gives a picture like the presentation of Ghassan, of resistance and fighting on. And but one wonders at this world that we live in. It is unbelievable. So let's see what you have, whether you have questions. I saw in the chats, I saw that there was a comment, at least from Harry. I don't know that I can find it now. Did you see it, Ghassan? He was talking about what's happening in Canada.
Yes. I mean, yeah. Canada. What I wanted to basically try to allude to is that we need to start understanding this crackdown on Palestinian expression of Palestinian national identity within Europe, within North America, not just as related to foreign policy alliances of these these governments with Israel, but also as a response to the increasing number of Palestinians who find themselves living in these, and this dilemma of being a citizen in the metropole that produced the settler colony that's trying to eliminate you. And the interesting thing about the term that Patrick Wolf uses to define settler colonialism, which is elimination, that it goes beyond physical elimination into politicide. So, you know, what is happening, what is being attempted in this metropole, in this Western metropole, is the politicide of these Palestinian newcomers into this political space to try to neutralize any effect that they might have on foreign policy in these countries.
Okay, any questions that do I see any hands? Because I can't find the chat. I don't think there's anything in the chat anymore. Now, I think one wonders when one hears this this presentation, the extent to which people can be pulled, the extent to which any people can be pulled and still they bounce back, as we say in resilience. It's been unbelievable, and one finds it in new generations too, which is one is only living the present, but what picture of the future? I mean,
Huda, so I mean, for me, the important thing to kind of to start thinking about as Palestinians is this idea that the dire situation faced by Palestinian refugees in Lebanon, in Syria as a result of the war, in Iraq as a result of the expulsion in Kuwait, all of these aftershocks that sent Palestinians on their second and third and fourth exile should not be viewed as the end of Palestinian dispossession. That somehow they now have gotten to a place where they are able to exercise sovereignty as citizens of these countries, but actually as another phase of dispossession and another phase which requires by the colonial project their elimination as Palestinians, their silencing as political subjects that identify as Palestinians. And then, so we need to kind of, because when the situation gets in Lebanon so bad that Palestinians, when they get to Europe, should somehow be just grateful that they're in Europe, or that the Palestinians from Syria should be grateful they're now in Canada. And they're so, that kind of gratitude that is expected of the refugee not to rock the boat by demanding some kind of national right. That's the dangerous bit. Of course, the Palestinian political establishment is so far behind in trying to kind of understand this new phenomena that, you know, we need to kind of be pushing for it as academics and activists.
Yeah.
Please, Osama.
Yeah. So again, just to elaborate on Ghassan's sentence, I think, you know, kind of we're in a situation, and I think that nobody planned this, right? Because if you look at you know, Herzl's writing of the Alt Neuland, or the, you know, the Old New Land, his imagination of the Jewish state, it doesn't contain Palestinians, right? Like the imaginary does not contain us. And yet the world in 1948, you know, was not a world where these massive scale massacres could happen, like the ones that happened in the Americas and Australias and so on. So that's kind of created this this strange يعني التناقض, contradiction, where you have a settler colonial state, but you have almost 50% of the indigenous are there on the same land, are not eliminated. So of course it will lead to these brutal struggles also in the Naqab and in Ghazi and in the West Bank and on all the frontiers. But you know, we're here and you cannot erase us, right? And at least you cannot erase our us also, not only as biologically, but as political subjects who are there and writing and having a plan for the future and so on. So it's of course kind of hard to think about the future, but it's also good to have some kind of hope in what we're seeing, and in a lot of comrades who are committed to anti-colonialism, anti-apartheid struggles, and yeah.
So one of the phenomena of settler colonialism is the everydayness of violence, and that's a kind of term that was taken from feminist literature about everydayness of violence. And one of the things that, and it's, you know, coincidental that both Osama and I wanted to also end our talks on, is the everydayness of Palestinian resistance. Actually, Palestinian resistance, and that's where I brought the title, you know, the sum of all of our struggles. It's that everydayness, that wake in Reading, in just outside London, where people from 1948 Shajara and Ain al-Hilwa sat to basically perform a social duty that had been performed by Palestinian communities for thousands of years, where you have the Aza after the death of someone, and there are 3 days and everybody goes to the house, or the everydayness of Palestinian resistance inside the Green Line, or the everydayness of Palestinian resistance in Australia or Canada or the West Bank or Gaza, beyond the large resistance, the politicized resistance. It's that everydayness of resistance that expresses itself everywhere, that Palestinians are.
Mm. Yeah. I think we have 2 hands in the chat.
Do I recognize? Yes, sorry. There's Graham and there's Mamdouh. Who wants to go first? Mamdouh? Sorry, Graham. I'll give you next. Mamdouh?
Yes. Actually, I have just a couple of comments. Extremely excellent presentations, both by dear friends Ghassan and Osama. As for anti-Semitism, I want to point to the fact that now the anti-Semitism is directed not only to any form of Palestinian expression of rights and identity. Any non-Palestinian, any European, any North American, whether a citizen or a politician or an NGO that criticizes Israel, just any criticism to Israel is labeled as anti-Semitism. And we know when the report of Human Rights Watch about apartheid, and then the Amnesty report to the same effect, they were labeled as anti-Semites. So this is a new development. And a lot of European governments and parliaments are going in line with this. The other point, the fact that in Palestine now, from the sea to the river, the historic Palestine, the Palestinian population is almost exceeding 50% of the population. So in spite of all the measures, on the demographic level, we are there to stay. And the Sumud and the resistance are working in spite of, against all the odds. A third point I would like to raise, that what we are witnessing in historic Palestine now is there is a new model of apartheid. It is much, much different from the apartheid model that used to exist in South Africa before the dismantling of the apartheid regime. Because in South Africa, they did not aim at expelling the indigenous people. They just separating the black population from the European population and to exploit their labor force. In Palestine, the aim of this apartheid is to try to make the Palestinian life as difficult as possible to live beside the active process of expulsion. So there is, as Osama pointed out in his presentation, that settler colonialism unravels in history in different forms. And now we are witnessing the harshest model of apartheid and settler colonialism. Thank you.
You want to speak before I give Graham? Go ahead, Ghassan. And
there's something very quickly I want to say that that's very unique about Zionist settler colonialism and Palestinian health, and that is in South Africa. African labor was needed by South African capital to extract value from the mines. What has been happening in the last 30 years, particularly in the last 30 years, with the growth of the Israeli arms manufacturing industry and where the Israelis excel, which is that management of surplus populations industry, the kind of militarization of policing industry, means that the Israeli capital now does not need Palestinian bodies to mine, to extract capital value from the mines. Wounding of Palestinians by these companies that are manufacturing and then using the act of wounding of Palestinians to market these weapons globally has become the extractive mechanism by which capital is generated by the indigenous population. So rather than being the labor that is used in the mining process to extract capital for the settler economy, our bodies and the act of wounding, the bombings in Gaza, the checkpoints in the West Bank, are extractive mechanisms by which Israeli capital produces surplus value through this new industry that Israel now is a field leader in, that globally markets itself in the management of surplus populations that need to be policed in a militaristic way. Sorry, Graham.
Okay, well, no,
yeah.
don't apologize. I thought these were really two very strong additions to the LPHA program. They weren't research presentations, but they were scholarly presentations drawing on a range of evidence and experience in order to make a case. And I think that's a valid type of thing for the LPHA to have. So thank you very much to both of you. My comment, which I put in the chat, was just I'd looked at population projections for 2040, which projected 9 million Palestinians in the West Bank, Gaza, and Israel, which would be more than the number of Jews in Israel, suggesting that despite everything, the plan for the Palestinians to disappear voluntarily or by other means is not working. And therefore, the Palestinian present and future is a real thing, and it's something we can support without necessarily being anti-Semitic. And I'm just wondering what the two speakers feel about the fact that despite everything, the demographics are in Palestinian favor.
Thank you, Graham. I would just like to say a very quick note on this whole issue of Semitism. I note that the first reaction of Palestinians when we hear about anti-Semitism is to say that we are Semite too. But I think we should really reflect on that. And there's a lot of writing by Joseph Mas'ad mainly on this issue of the creation of the Semite. So just like we said, racialization and racism is a product of its own environment, and how in Ireland, and the UK, these categories of the Protestant versus the Catholic were created to enforce systems of racism. In Europe, the Semite was created, it's a biblical category. It does not have anything to do with biology or so on, just like black or white or yellow or red or so on. It was created in a European context to differentiate between Christians and Jews and people who can join the European modern project, of the nation state of Germany and so on, versus people who are not allowed. So I think we should problematize, this concept of Semitism, not to say that we are Semite too, but to say that Semitism and anti-Semitism were created in Europe, and they operate very differently in the Middle East. Also, it operates very differently compared to Mizrahi Jews and Jews who have been living for ages in Iraq or Morocco or so on. So not just to understand Semitism in its European context, and then to say how it was weaponized by Israel and by other states and kind of outsourced to other Palestinians or Arabs. So now, Muslims and Arabs are accused of anti-Semitism instead of Europe and so on. So it's a bit more complicated. And yes, of course, we're here to see, there's a lot of I studied public health in Tel Aviv, so even the whole school of to study about demographics was with this, how do we incorporate Aliyah with encouraging Jewish migrants and settlers into Israel versus working to lower the birth rate of Palestinians, versus there's this entire industry of fertilization and assisted reproductive. Israel is kind of an empire in reproduction therapy. So it is an ongoing struggle and this, of course, will lead to more violence, because you need to maintain a majority, at least in different compartments, right? This is why Gaza was created from the first place as this dumping ground, for refugees, and why no matter how our number inside the Green Line has increased from almost 150,000 to 2 million, but still on the same ground. So you will see much more. And in Jerusalem, there's this ongoing struggle, so more home destruction, land confiscation, and kind of these manifestation, and more resistant to it. Until, maybe we can all live freely and equally in this place.
But please correct me if I'm wrong, but my impression is that Israel doesn't have effective means to address the demographic issue.
So my feeling is that the effective means have just been expressed recently. I'm currently in the West Bank. I was in Nablus yesterday. I was in Jenin today, and it's obvious that even the Israeli security and political establishment were shocked, or were at least surprised, by how much further to the right the Israeli electorate voted than they were expecting, to the point where we now find Netanyahu lying on the left of the Israeli political spectrum, Ben-Gvir in the mainstream, and then there's a load of other people to the right of Ben-Gvir. And so this ideological preparation to solve this issue, this problem that you discuss, Graham, which is the population issue, is already underway. And we're watching this move where the shift within the political sphere keeps moving to the right until the unspeakable becomes mainstream and the unthinkable becomes very thinkable, in terms of expulsion, in terms of massacres, in terms of physical elimination.
Yeah, and just to add to that, so inside, there is also has been some writing on this issue. inside the green line, how can Israel, decrease our percentage and number more and more? And there was even really discussions whether, what do they prefer, a kind of a Palestinian woman who is poor but has a lot of children, but a woman who is educated, has less children, but has the potential of becoming politicized and kind of more active in political movement. And of course, this discussion led that they prefer an educated woman that has less children rather than a kind of a poorer woman. And we can see that with time, of course, the overall fertility rate has dropped down for Palestinians, as has increased for Israeli Jews. And in 2018, it was actually celebrated that within Israel, Jewish mothers have more kids than Palestinian mothers, So there is this tension and struggle around the demographic and fertility and so on. I've wrote something about it recently. I will put in the chat. But yeah, these struggles are happening in different places and in different intensities. I think Jerusalem.
I would like to switch a little. I think we're over time, but this is so very important. And excuse me, we have electricity cut. It will come at 5 o'clock. I am thinking that the solution for many of us and for our region, for Lebanon, not only for Palestine, is in the political system that we are held, I don't know what to say, we are imprisoned in. We are imprisoned in a political system that does not allow us to move favorably forward. And I think this is also the situation in Palestine. And I wonder whether you see any hope in moving the political system so that, because also the political system is the creation of Israel, and it is with the purpose of just keeping the political activity or any kind of demands in check. This is the same for us in Lebanon. We feel we are, it's a hopeless situation because we can't do anything about it. And this is very bad. So how do we, if we look at it the other way, how can we deal with the politics within Palestine? How can we make some breakthrough in the Palestinian politics, if we can? If I may pose this question, which frustrates me so much in our country.
I mean, internally, in terms of re-articulating a Palestinian national project that is the sum of all our struggles, and that expresses the struggles of Palestinians in Al-Araqib and in Tarshiha and in Canada and in Sweden and in Ain al-Hilwa and in Jordan and in Syria and in Iraq and in Gaza and the West Bank, that internally we are stuck as Palestinians. We are stuck in the West Bank with the PA. We are stuck in Gaza with the siege and the siege in Gaza. We are stuck with a dead PLO that nobody wants to sign us a death certificate on because it suits everybody for it to be dead, but not certified dead. We are stuck in the absence of institutions, Palestinian institutions, like the Palestine National Council, that again can be representative of all Palestinians. In terms of the struggle against the colonial project will only change when it's defeated. And that's the dilemma, is that we continue to struggle against the actions of the colonial project, but we are unable to affect its essence. And internally, we are unable to organize ourselves nationally again in any coherent way that brings together all of these struggles that are a result of this one colonial project.
Yes, which transcends the situation in Palestine too, I may say sadly. Shall we end? What time is it? It's 5. We were supposed to end at 10 to 4 or something. But I don't see anybody complaining that we moved forward. This has been a wonderful session, very reflective, very important. And in the name of everyone, I would like to thank both of you for these very moving and thought-provoking presentations. So thank you all.
Thank you, everyone.